ઝઘડો બી થાય તો વાંધો નથી, પણ એક નવું અહીંયાથી આપણે નીકળે તો લાગે કે કંઈક બીજો પોઈન્ટ ઓફ વ્યૂ આપણને મળ્યો. એવું નહીં કે જે બુકમાં આપ્યું હતું એ તો જે રોનકે કીધું યુટ્યુબ પર વિડીયો જોઈને આપણે બી જોઈ લેવાના છે. પણ જે એક્સપિરિયન્સ થી જે વસ્તુ આપણે શીખીએ, જેમ કે હું એક એક્ઝામ્પલ આપું કે સુદર્શનભાઈ છે એ પ્રેક્ટિસલી હિંમતનગર. સો અમદાવાદના પેશન્ટને ટ્રીટ કરવા અને હિંમતનગરના પેશન્ટ ટ્રીટ કરવાનો ઘણો ફરક છે. એ પેશન્ટ એવું હોય કે 1 મહિનો તો ફિઝિયોથેરાપી વાંધી વધારે કેટલી કરવાની, 3 મહિના તો કોઈ રોટાવેટર કફ માટે આવે જ નહીં. એવી જ રીતે વિજયભાઈને બી સેમ વસ્તુ થતું હશે કે ACL ની સર્જરી કરાવી, સર 15-20 દિવસ કરાવી ફિઝિયો, એમથી વધારે કેટલી કરાવવાની. સો દરેક તમારામાંથી બી ઘણા બધા લોકો હશે કે જે પેરીફરીમાં જશે, ઘણીવાર ગવર્નમેન્ટ હોસ્પિટલમાં જોબ કરતા હશે, તો પેશન્ટના માઇન્ડસેટ, એનો સોશિયો ઇકોનોમિક સ્ટેટસ, એના IQ લેવલ, એની એક્સપેક્ટેશન્સ, એની અફોર્ડેબિલિટી, એના રિલેટિવ્સનું પ્રેશર, ઘણીવાર ઓપરેટિંગ સર્જનનું પ્રેશર હોય, એ બધાની સાથે ડીલ કરીને કેવી રીતે રિઝલ્ટ આપવું, સો એ બહુ અગત્યનું કામ અને અઘરું કામ છે. એટલે જસ્ટ આપણે ખાલી હજુ વી હેવ લોટ ઓફ ટાઈમ અને મેક્સિમમ તમારો બધાનો ઇન્વોલ્વમેન્ટ થાય એવો મારી ઈચ્છા છે. રોનકે જે એક્ઝામિનેશનનું જે ટોપિક લીધું, ઇટ વોઝ એક્સ્ટ્રીમલી ઇમ્પોર્ટન્ટ ટોપિક, અને બહુ ડિસ્કશન ડિટેલમાં એને ડિસ્કસ કર્યું. જસ્ટ જે 3-4 પોઈન્ટ બીકોઝ આપણે બ્રેક લેવા પડ્યો રહી ગયા, તો હું ક્વિકલી કવર કરી દઉં. અને જે બહુ કોમન ટોપિક છે એ છે સબ એક્રોમિયલ ઇમ્પીચમેન્ટ. સબ એક્રોમિયલ ઇમ્પીચમેન્ટ એની એજ ગ્રુપમાં થઈ શકે. વાય એની એજ ગ્રુપ, બુકમાં તમે જોશો ને તો યુઝ્યુઅલી ઓલ્ડર એજ ગ્રુપ લખ્યું હશે, બટ બીકોઝ ઓફ ધીસ various exercises, wrong gym exercise, posture, you will see lot of subacromial impingement nowadays. So subacromial impingement નું ટેસ્ટ કરવા માટે there is one test which is called Hawking-Kennedy test. right? શર્ટ કરવાની જરૂર નથી હોતા. Hawking-Kennedy test. So one thing I will add, કોઈ બી ટેસ્ટ હું કરતો હોઉં ને તો I would stabilize the scapula first. One important mistake which I think, suppose if you are examining the supraspinatus, they will check abduction in this position. Now if you see in first lecture, Nikun sir said that scapula is 30-degree anteverted. So the angle of the supraspinatus is also 30-degree in this position. So whenever you are examining supraspinatus, it is not in this position, but it is 30-degree. So you internally rotate, passively stabilize the scapula, or put your hand over scapula and then check for resistance, like this. So that is one thing. In impingement, basically you are recreating the pathology by doing the test. So you want to hit the acromion, undersurface of the acromion, by forward flexing and then internally rotating. So this will recreate the pain of the subacromial impingement. There are many other tests also. No need to remember the fancy like needs test, jobs test, these tests. The patients don't want the fancy and they want the diagnosis. That is the impingement test. Second, AC joint arthritis pain. So the most important you can do is the palpation. And sometimes you press so hard that patient gets confused. It is really that painful part or other part. So you compare with the opposite side and give equal pressure on the both the sides. Then ask patient that which side is more painful. Similarly, there is the cross body adduction test for the AC joint, like this. Or you can do in this fashion for AC joint. For biceps tendinitis, especially in the overhead athletes, you will come across many patients with biceps tendinitis. So you put a thumb here, do internal external rotation. You will feel a cord-like structure here, especially in thinner patients. And if the pain is there over that area, then the confirmation of biceps tendinitis comes. There are many other tests also, but quickly concluding, supraspinatus, infraspinal rotator cuff tear, apprehension test for instability, impingement, adhesive capsulitis, you do passive external internal rotation, and for AC joint you do painful, you do the arc and check at which moment the pain starts. So you can write down your case sheet that after 90-degree the pain starts. There is one modification of the drop arm test. You basically lift the arm and ask patient to bring it down. So basically he has to have a good eccentric control against gravity. Sometimes the arm will not drop, he will be able to come down, but at certain degree there will be sudden catch. That is also comes within the drop arm test. While coming down, patient will complain of the pain. Now we are moving towards the instability. Instability is increasing day by day because of the multiple accidents, sports, overhead athletes. So what is instability? There are many ways of instability. So what happens when the shoulder dislocates? So shoulder is a ball and socket joints supported by a glenoid labrum and the ligaments all around. So which are the static stabilizers? Labrum and the glenohumeral ligaments are the static stabilizers, and rotator cuff muscles and other periscapular muscles are the dynamic stabilizers. So whenever there is anterior dislocation, there will be detachment of the anterior inferior glenoid labrum. That is known as Ronak. बोल उनको देना. Antero inferior glenoid detachment known as Bankart lesion. Yes, and at the same time there will be a defect on the humeral head, which is known as Gaurav Hillsat lesion. Yes. So whenever there is a traumatic dislocation, there will be a damage of static stabilizers. So now. So, just a hypothetical situation, I am shifting you towards a condition where there is a person who is walking on a rope, like this. You can compare this with two bones, bone number 1, bone number 2. Together they are making a joint, and there is a connecting tissue which you can call a ligament. So there are how many ways this structure can become unstable? How many ways? So number 1, these ropes get broken. That is ligament rupture. So ligament rupture usually happens because of any trauma. So first condition is traumatic episode which leads to ligament rupture. So once you know the mechanism of injury which led to the instability, you know the treatment. So what will be the treatment in this case? For an example, there is complete ACL rupture. What will be the treatment? Reconstruction. Similarly, in the shoulder joint, when there is a Bankart lesion after trauma, what will be the treatment? So in certain ligaments you do reconstruction, and in certain ligament you do repair. So if we say MCL rupture, we usually do MCL repair. ACL rupture, we do ACL reconstruction. Shoulder ligament rupture, we do ligament repair. So it is known as arthroscopic Bankart repair. There is another condition when there is no ligament rupture but ligament detachment, which is also known as ligament eversion. For an example, ACL eversion, PCL eversion. So what is the mechanism of ligament eversion? Again, trauma, history of fall on outstretched hand or fall from the stairs. So what is the treatment for ligament eversion? Same, you do surgery, you can do repair. So here we do, if you see this X-ray, this is humerus, this is glenoid, and there is eversion of the inferior glenohumeral ligament, which is known as bony Bankart lesion. So here, do you think with rehab and strengthening the dynamic stabilizers, yes, the stability will improve, but this will heal on its own? No. So what treatment would you offer in this case? Surgery. Yes. So that was the second mechanism of instability. Now third, the ligament is lax. There was past history of any injury. The ligament is lax. Now in this case, if you tighten this ligament, after some time this pole will again tilt down and ligament will become lax. So in certain conditions, when there is bony deformity and malalignment and there is ligamentous laxity, what treatment do you give? Treat ligament first or do you treat the underlying deformity first? For an example, there is varus deformity gross. The lateral structures will get stretched over a period of time, and there will be a pseudo laxity of lateral collateral and other structures. And if you do surgery and tighten the lateral collateral ligament, do you think it will stay like that forever? No, the deformity will increase. Similarly, in the shoulder joint, when there is a repeated dislocation multiple times, especially in our country, people don't come to the clinic easily. So there we have seen patients who have 50 dislocations, 30 dislocations. And because of repeated dislocation, there is glenoid loss, deep Hill-Sachs lesion, And when there is an excessive bone loss, the socket size comes down like this. There is an attritional glenoid bone loss, and if you tighten the ligament, do you think that that will stay tight forever? No. So in that case, you have to treat the underlying deformity first, that is correcting the malalignment. So in knee joint, if we say there is a varus malalignment, we do corrective osteotomy. Similarly, in the shoulder joint, when there is purely a soft tissue condition, we do arthroscopy. But when there is a bone deformity of the knee joint, we do the open surgery, that is known as the Latarjet surgery. We transfer the coracoid process over the anterior glenoid to increase the bone surface. So first three we discussed was ligament repair, ligament eversion fixation, and the bony deformity correction. Now the fourth cause, there is no history of any injury, no trauma, still patient has instability. Patient comes to you, you examine, and there is laxity also. What could be the cause? Hypermobility, yes. Connective tissue disorder, generalized laxity. So whenever there is atraumatic instability, you always suspect generalized ligamentous laxity, some collagen vascular disorder. So do you think if we do surgery and tighten the ligament, it will stay that like that forever? So there is no role of surgeon in certain cases of shoulder multidirectional instability or generalized laxity. And so as no generalized laxity also, still the joint is unstable. So here you focus on dynamic stabilizers. There can be disorder like polio, cordyceps is not functioning, knee joint is unstable. There is some neuromuscular disorder, deltoid palsy, shoulder will become unstable, inferiorly migrated. So whenever there is a atraumatic instability, either there is a generalized laxity or neuromuscular instability. So to sum it up, there are five cause: ligament rupture, ligament eversion, bony deformity, generalized laxity, neuromuscular instability. First three are traumatic, these two are atraumatic. Now traumatic, I usually divide into two parts. We come across many athletic players without any evident history they have instability. So trauma you can divide into two parts: single traumatic episode and repetitive microtraumatic episode. So shoulder instability you can divide: overhead athlete have overuse. If some volleyball player is there, they will have a hyperangulation, and because of repetitive hyperangulation, they can have a subluxations. And post-traumatic dislocations are simple. They fall from bike, fall. Finally, there will be a posterior, but most common is anterior-inferior, which is known as the Bankart. So this was the basic of instability. Now, how to approach the instability, how to do rehab instability, advanced management, and post-operative rehab. I would invite Ketan Pandya sir. He is a senior lecturer in SBB College of Physiotherapy, and Srinath. He is a sports physiotherapy. Both of you, please come and enlighten us regarding the further disability. Thank you.
So orthopedic surgeons are great people. They deal with structures which don't respond. Brain says anything to the bone, bone doesn't respond. Brain cannot command bone, neither the joints. We are lucky. We deal with structures which responds. Brain says muscle contract, muscle contracts. Brain says muscle relax, muscle relax. So we are more privileged to work with structures which listens to and which follows. And these are the same structures, if they don't listen to, they create a problem. So the very basic of physiotherapy, you work more with the muscles, and as sir mentioned, different types of instability and how does the instability occurs. So let's see some slides.
So as sir rightly explained, so can anyone tell me that which type of instability occurs in such cases? Anyone from the audience? From the last, anyone? કઈ ટાઈપની instability થાય if આવો સિનેરિયો હોય તો? ટ્રોમેટિક છે તો આપણને ખબર પડે છે, પણ તમે ડિરેક્શન જો જે રીતે પડે છે બરાબર એથ્લીટ, તો તમે બોલો કે કઈ ટાઈપની ઇન્સ્ટેબિલિટી આમાં થાય. એનીવન રેઝ યોર હેન્ડ. ઉત્સવ ઉભો થા. બોલ.
Posterior? No, we are not directly jumping to diagnosis. It is which type of instability do you see in this case? Basics. Non-traumatic, traumatic, unidirectional, multidirectional. Traumatic.
Yes, traumatic. The forces are directed in one direction, multi-direction, unidirectional. Traumatic, unidirectional. So it's a kind of tough say. Traumatic, unidirectional, probably bank cards would be involved and would respond to surgery. Okay, fine. Good work. Please respond. Even if you are wrong, that's okay. We are not going to shoot you. Right? So all the three of the figure shows the traumatic anterior dislocation or subluxation or instability of the shoulder joint, and the middle one you need to know for your self-defense. Okay, this one. Anyone, please?
Anyone from the audience?
Yes, please, please. खोटो तो खोटो बोलो तो खरा.
Come on, speak.
Posterior, good one. So if there are two options, left and right, and if one has said left, then you are left only one option right. तो ये तो बोलो चाहिए. So this is posterior instability, traumatic posterior instability or dislocation. There are two different figures. So one is traumatic, as you see, by fall on the elbow. Another one is electric shock. Posterior dislocations are often seen with electrical shock, wherein there is a very strong muscular contractions which dislocates the humeral head. Similarly, it can occur in patients with epilepsy, also epileptic attacks. Next. So, sir said traumatic and non-traumatic. We finish off traumatic. This one is
Non-traumatic.
okay. So, or we will say micro-traumatic. I will not say non-traumatic. This is micro-traumatic. Why? Okay, we don't go relate to these people. We relate to bowler. We relate to Jasprit Bumrah. We relate to Mohammad Shami. So they throw repeated overs. If it's a test match, number of overs to be thrown. Over a period of time, what they do is the wear and tear will take place over a period of time, over long term, and that will cause maybe loss of bone, possibly, or they will cause laxity of the structures, and that can lead to instability. Okay, so this is atraumatic kind of instability, inducing very commonly in sports, especially in overhead athletes, or anyone who is in throwing or hitting, striking, jump, like someone like swimmers or javelin throwers or tennis players, badminton players, most of.
Now coming forward to the phases of throwing, as you can see. So moreover in the throwing, the action is like the abduction and external rotation, as sir said. Then it can cause the tightness in the posterior capsule, as you can see. So you can see that there is a drastic change in the internal rotation of the figure you can see over here.
So this is. Yes, please, louder.
Yes, GIRD.
Okay, so the slide there is restriction of the internal rotation compared to the external rotation, and that is what commonly happens very often found in baseball pitchers. So types of instability, as I mentioned, we put it down. We are not going to go into the details of now. As my dear colleagues mentioned earlier to you, they have highlighted to you what are the important structures we need to focus on in terms of biomechanics, dynamic stability of the shoulder. So as I said, my initial briefing was just to make a platform. Scapular recapitation initially, in case of, say this is a post-traumatic conditions operated, and we have to start with. Then our focus would be starting to set the scapula, to rehabilitate the scapula. Why? I mean, you know the correlation, they are already correlated scapula, it's a glenohumeral joint. But why do we focus on the scapula first then? So, the rotator cuff, which I mentioned, the dynamic stabilizers on which we are going to work by and large. Yes, please.
I just gave your answer. You asked now why is scapula we should work on. So I said it is a part of a force couple that has an active role on glenohumeral stabilization.
Yeah, sorry, I missed. So, the rotator cuff needs to work to stabilize the glenohumeral joint. The dynamic stabilizers, they need to steer the glenohumeral joint, okay, within the glenoid socket. But when they will work, they can only work if the scapula is stabilized. No rotator cuff can work if the scapula says, I am out. Right? So, why we need to focus on the scapula stabilization initially in post-operative conditions. Herein, this is more of the TURPS kind of post-operative rehabilitation we are speaking on. But apart from few important things, for example, if it is anterior dislocation, we need to be careful for external rotation and abduction initially for a couple of weeks, about 6 to 8 weeks probably. And if it is posterior dislocation, flexion, adduction, and internal rotation in the initial maximum protection phase. Apart from them, more or less the rehab procedure would follow on the same line.
Now moving forward to the post-operative rehabilitation guidelines for the shoulder joint. So these are the basic factors upon which the rehab would be lied on. So for example, the first factor is the onset of instability. So if it is a multidirectional instability, then the more conservative approach would be used. Means there would be no surgical procedure, as Rohan sir mentioned. So we would go on the conservative management by the strengthening of the scapular as well as the rotator cuff muscles. Then we should also check for the severity of any associated lesions. So if there is any bony involvement around the structure, then we should also focus on that part by sir mentioned, and then we should do rehab accordingly. Then if there is a failure of any surgical stabilization, then there would be a slower progression in the rehab. Then we should also focus on the direction of instability. As the anterior instability, no operation થયું હોય, surgical procedure થઈ હોય, તો એના પછી જે rehab છે, that would be more easier as compared to the posterior dislocation. Right. Then the type of procedure. Then the electrothermally assisted capsulorrhaphy requires slower progression. એમાં rehab તમે જુઓ તો ઓછું હોય comparatively, મતલબ time frame કહું છું. તો એમાં time frame comparatively ઓછી હોય આના કરતા. Then the patient variables also. Okay, how is the patient is the compliant with our rehabilitation procedure. So these are the factors which we could keep in mind while treating these cases. Now talking about the immobilization, that for how long the shoulder should be immobilized. Can anyone know that up to what weeks the immobilization is allowed following the surgery? Anyone from the audience? Anterior dislocation થયું હોય, એનું ઓપરેશન થયું હોય, તો એના પછી જે ઇમોબિલાઇઝેશન માટે સ્લિંગ આપીએ, તો એમાં કેટલા વીક્સ માટે ઇમોબિલાઇઝ કરવાનું? What?
I preferred the orthopedic decision in this.
Yes, but generally for the idea.
They have done the surgery, so they will always guide us about
Yeah, exactly. But એના ફેક્ટર્સ કયા હોય, કઈ વસ્તુ ઉપર વધારે ધ્યાન રાખવાનું?
So immobilization always usually એ લોકો આપણને guide કરે initial phase.
Yes, so the surgeon will definitely guide us how long, because it's their forte, they will say when to start mobilization.
So I will ask Parthovi, if the surgeon is new and he doesn't have experience and he asks you, Parthovi મારે immobilize રાખવું છે, કેટલું રાખવું?
So depend on the surgery again, કેટલું તમે શું repair કર્યું છે કે હા.
So if you do the anterior stabilizer,
Yeah.
what from your knowledge, what would be the position of the immobilization? Neutral position, internal rotation, or so you should give arm pouch or immobilizer like this? What do you prefer?
I preferred slightly abduction and neutral position rather than the internal.
Reason?
Internal rotation માં થોડું compressions વધારે થાય તમારે. Again તમે internal rotation માં રાખો તો. So if you keep it abduction and with the neutral rotations, that will heal more better ways.
Yes, so he is right. Our normal logic એવું કે anterior repair કર્યું છે, હાથને આમ રાખો તો anterior tissue relax હોય. but there has been studies કે પોસ્ટ ઓપરેટિવ MRI કરી જોયું છે કે if arm is slightly abduction and neutral position, the healing is better. So the ideal position of immobilization after surgery is around 10 degree of abduction and slightly neutral to slightly internal rotation.
ઓકે ધેન બીજી કઈ વસ્તુ ધ્યાનમાં રાખવાની કે કોઈ ઓલ્ડર પેશન્ટ હોય આપણી પાસે તો એમાં ઇમોબિલાઇઝેશનનો ટાઈમ ફ્રેમ આપણે ઓછો રાખીશું કેમ બીકોઝ એમાં સ્ટીફનેસ થવાના ચાન્સ વધારે રહે તો એ બી વસ્તુ આપણા ધ્યાનમાં હોવી જોઈએ when you are dealing with such type of patients. Then the immobilization for the anterior shoulder instability would be like it is in a sling in adduction or varying degrees of abduction and internal rotation. Then talking about the posterior instability, the type of immobilization should be like in the handshake position. Then the duration can range from 1 to 3 weeks to as long as 6 to 8 weeks as directed by the surgeon. Then talking about the rehabilitation protocol, the starting from the maximum protection phase, the time frame is generally from day 1 following the surgery to round about 6 weeks, and the rehabilitation goals in the maximum protection phase are to protect the surgical repair, then to reduce swelling and minimize pain, then maintain the upper extremity range of motion in the adjacent joints such as the elbow, then hand and wrist. Then you should gradually increase the shoulder passive range of motion. Then you can also work on minimizing substitution patterns with the active assisted range of motion. Then you should work on minimize muscle inhibition by doing exercise such as the isometrics, and you should educate the patient first of all. And then what precautions that you will have to keep in mind while dealing with such patients are that, for example, there is the post-op anterior dislocation, then you should be precautious while doing that. There would be no shoulder active range of motion being done by the patient, then no lifting of objects, then no supporting of body weight with hands like this. Then for the post-op posterior dislocation, avoid excessive shoulder flexion, adduction and internal rotation in the immediate post-op period. Then starting with the intervention. Sir.
So over here the most important, am I audible? So the most important factors over here would be in the initial phase to start with would be to minimize muscle inhibition and to minimize substitution patterns with active assist range of motion. Why? Because if the patient is coming to us post-op, he would be immobilized for a couple of weeks, maybe 1 week, 2 weeks, 3 weeks as advised, and then he would come to us. So by that time the structures are relaxed, they are not working. But someone, mostly all of would be saying the shoulder patient, say someone with shoulder pain, no cause. So mostly the patient will turn to the therapist or the surgeon usually after 2 to 3 months of the onset of the pain. And by the time they come to us, what they do is, why? Because body works in a wonderful unity. So the body says, the muscle says, okay, if you are not able to work, I will work for you. So if the shoulder flexors along with the other supporters, if are not able to perform shoulder flexion, okay, the work is done. The work is still done. Yeah, so that is why, and this is the phase where we can make our task easier, because once the patient gets into this position, unlearning that and then learning the new pattern is really a headache. Because to ask the patient to relax, it's very easy to say relax, but whether the patient relaxes, it's very difficult. So before going on further on the rehabilitation, may I have anyone who is saying champal ma koi છે? I want someone with naked feet. કોઈના પગ ખુલ્લા હોય એવું એક જણ આવી શકે? Yes, please.
Yes, please come.
And to me this is the most difficult of the exercise, and I can bet not less than 50% over here would be able to perform it. કદાચ એના કરતા બહુ મોટો આંકડો હોય પણ 50% ઓછામાં ઓછા 50% લોકોથી નહીં થાય. So you can sit here or in a chair. It's okay. Yes. It's not difficult because of its difficulty level. It's not difficult because I just want you to perform this section. Just view what's happening. Are you able to? What is happening?
Fingers are moving, but
You don't know how to move this braid,
yes.
right? Why? Is it a very difficult exercise? I mean, it requires a lot of strengthening or skill or anything? I don't think so. But it's very difficult, and I still say not less than 50%. કદાચ 80% 90% લોકોથી નહીં થાય. ઘરે જઈને ચેક કરી લેજો જે લોકો શૂઝમાં છે. And why? Because the muscle has forgotten how to work. The muscle, because we have caged up the muscle, it's not working. It's immobilized in the shoe. એટલે વર્ષોથી કામ નથી કર્યું. એટલે જ્યારે કામ કરવાનું આવે તો we know કોઈ કે હાથ ઊંચો કરો, કોઈ કે કોણી વાળો, નીચે નમો. We do all these things because these muscles are working. This muscle has forgotten to work. And same way for the shoulder muscles. Thank you. So when we come to the shoulder stabilization, that's why I mentioned that we need to check muscle inhibition. That is, unwanted contractions should not be there, and we need to correct the succession patterns by activating the correct pattern of movement. So moving on to the interventions. Initially, these are the data. Axial rotation in the scapular plane should be less than 20 degrees. That is the maximum protection phase. I will not go much into deeper of these data because you will be taking care of. જ્યારે આપણી પાસે પેશન્ટ મેક્સિમમ પ્રોટેક્શન ફેઝમાં હોય તો સાચવવાની જ વધારે જરૂર હોય. In instability, post-op instability, or with the hip instability, the single most problem which can occur is yes, reoccurrence. કોઈ પણ instability માં recurrence થવાના chances બહુ જ વધે છે, even after rehabilitation to the maximum. Because I had a shoulder patient, a young boy about 20 to 23, and he said, I used to play cricket and I want to play cricket. We said fine. And લગભગ 2 મહિના 3 મહિના પછી he was very fine, and by the end of 4 months we came to bowling. He was able to. So usually we go for 6 months or maybe more if the stability is not good, but he was very stable and he could do. એટલે અમે છેલ્લે જ્યારે physiotherapy sessions બંધ કર્યા ત્યારે we left at bowling. He used to bowl and I used to bat. So we stopped there and I said, okay, continue with the exercises, don't stop the exercises. You can go away, don't come to me for this now. So he was doing well, and one fine day they came back with again the history of recurrence. And how did it happen? Bed ઉપર બેઠો તો વાંચતો તો વાંચતા વાંચતા નીચે બેસવા ગયો. You could see the position of the joint. Dislocate થઈ ગયું. So even with the very good rehabilitations, very good protocols, we put in lot of strengthening and all, still there are chances that dislocation can occur. Recurrence of instability is very much possible. So in the initial phase, our focus would be to check. We do not stress the operative structures, the injured tissues. We take care of them. So to start with pendulums, okay? So pendulums are very easy activities. May I have anyone? कोई non-physio છે અહીંયા? I mean non-medical, non-paramedical. આવો ને? Thank you. અરે તમને તો બધાને ખબર જ છે, જેને નથી ખબર આપણે હાથ ઝુલાવવાનો છે એકદમ આરામથી, ઢીલો રાખીને. સારું લાગે છે? આગળ પાછળ કરો, એકદમ આરામથી ઝુલાવવાનું. So he is doing it. He is doing the pendulars. Okay? હવે હું કરું છું, તમારે કંઈ નથી કરવાનું. રિલેક્સ. તમારે કંઈ નથી કરવાનું, હું કરું છું. તમને કંઈ ફરક લાગે છે? તમારે કશું જ નથી કરવાનું. પહેલા કરતા ખભો હલકો લાગે. So he is doing pendular. But what we intend to do by pendular is to perform a relaxed movement. Okay, this is more basically to relax and then activate the muscles, both the things. So if the shoulder is not relaxed, when I say not relaxed, then there are other muscles which are working, not letting the shoulder free. So we need to relax, that is to avoid inhibition and perform relaxed pendular activities. Okay, so execution is important. આપણે pendular exercise કહીએ તો pendular is a simple exercise. આપણે first year physiotherapy માં પણ શીખ્યા હોઈએ. But when it comes to execution, that is where the difference would come up. તો તમને એવું લાગે તમે હલાવતા હતા ને અત્યારે આ હલાઈએ છે, તો ખભો રિલેક્સ લાગે વધારે, હલકું લાગે. Okay, so he could, you people know, but he doesn't know, so he could comment. Thank you. So the pendulums we could start with seated glenohumeral flexion. So initiating the shoulder flexion. Support. So this is supported shoulder flexion we are doing initially. Okay, in sitting position to start with. Same way. In standing position again. So we will be taking care of the range of motions. Initially, in the first week, we will try to go up to 90 degrees of forward flexion. Okay, then assisted shoulder flexion. This was also assisted for my patients. For my patients, when I say assisted, I say no use of cane, ladder, pulley, nothing. Why? Because many of the patients, when they start with, they will start with. So once they start this assisted, and then they are progressing. So we would always start with the short lever arm because the muscles do not have good enough strength to control the long lever. To reduce the load, short lever arm, banye hath pakdo. Banye hath pakdo. So relax. Okay. Now because suppose this is affected, this is normal, this is going to support this side as much as possible. I tell જમણો હાથ 2% કામ કરે તો 2% કરાવો, 98% સપોર્ટ આપો, પણ એ 2% કામ કરવો જોઈએ. So it should not be that it's totally passive, it's active assisted, and the amount of support by the non-involved extremity will reduce as the affected extremity can perform. Okay, so initially to check the range. So I હાથને માથાની નજીક રાખવાનો પ્રયત્ન કરવાનો છે. And I will support, so I am not actually assisting the movement, I am just guiding the direction and I am checking whether he is doing it rightly or not. So otherwise what will happen is initially the patient will start with, most of the patients will start in the long lever arm, and if I ask them to perform short lever, what they will do is, so what is happening is, it's not the shoulder flexion they are doing, it's they are extending their elbow because they find it more comfortable. So what I would do is, okay, whatever possible.
Question, sorry. So can we do it something else rather than? Okay.
So question એ છે કે આપણે હાથ યુઝ કરીએ એના સિવાય કઈ બીજું ઓપ્શન્સ કરી શકાય?
Yeah, definitely. We can use wand as we have.
So wands or either I feel કે external cueings આપીએ rather than the internal આપણે કોઈ બી inputs આપીએ એના કરતા, because already we expect the muscle gardening છે ત્યારે, so we just want neuroplasty reduce કરવા માટે. So when we use our hands, again neuroplasty ને આપણે reverse નથી કરી રહ્યા. So rather than keeping your hands આપણે ઉપર રાખી દઈએ and if you ask to touch the wrist, so automatically આપણું એ થઈ જાય, autonomously train કરી શકીએ.
No, definitely we can do that, and that is definitely going to help. That can be the part of our program, the next step. Initially, just to make sure that they are going into correct pattern of movement.
Right.
Once we are confident that patient is performing right pattern of movement, that is, I think, is more important, because doing this is not going to help ever. So once he is able to perform this, otherwise what they will do is this. So once they are able to get into the groove, then we can definitely imply what you are telling.
If our muscle pain that, then advanced we can do.
Because I have seen patients rehabilitated post-op for fracture something, and my focus on gaining this, and a સરસ movement આવા લાગીને, then I was off for a week or so. I mean, we did not get to see the patient. એટલે હું ત્યાં હતો નહીં એ ટાઈમે 10-1 દિવસ, અને પછી 15-20 દિવસ પછી પેશન્ટ જોવાનું થયું, then he was doing this. એટલે ક્યારે પાછી movement change થઈ જાય.
So for that I have one more options. Can we do it rather than sitting lying first? Because
Yes, definitely.
deltoid support ઓછો થઈ જશે. That's what we want basically.
Deltoid support ઓછો છે, scapula will be more better stabilized.
Right સાથે કરીશું તો એ વધારે
Yes, of
appropriate
course.
થશે.
Yes. So we can go into the supine position, એટલે in the
Trunk
sequence,
inclinations જેમ વધશે એમ deltoids assisted વધારે
yes, you are absolutely right. કદાચ એવું બને કે in the flow, if I am doing something in sitting, I will progress. એટલે પછી બીજી બાજુ પાછું લો લેવલે કદાચ બીજી પોઝિશનમાં આવે એવું બને.
Right.
But you are absolutely correct and good to suggest that we start with this. Usually we start in supine lying position only. We don't start in sitting position. But just to show you, I took him into the sitting position, that what we need to focus.
Right.
Yeah, sir. One more question. So like you have used a excellent concept of short lever arm and long lever arm, right? So I just want to add one thing, like why we work on short lever arm and long lever arm. So ultimately हमारा फंडा ये है when we treat the post operative conditions कि हमारा muscle का effort हमको कम करना है. That's the basic thing we want. So we are not working in long lever arm because we don't want muscle to generate the more force. And that is why we are taking into a short lever arm so that we can reduce the force generation. We can work on muscle activation more. So ultimately the goal is muscle activation, not the strengthening.
Yes,
Yeah,
just,
so-
just a small difference here,
Yeah.
that it's not about loading the muscle, it's about how much the muscle can do.
Yeah.
Muscle will go for trick only when there is overload. So you want to load optimally. Okay, 2 કિલોની તાકાત છે, 3 કિલો આપીશું. Simple example, આપણે કદાચ કોઈ દિવસ કોઈ બ્રીફ કેસ કે બેગ કે ડોલ કઈ ઉચક્યું હોય, if it is light 1 kg, we walk comfortably. If it is little heavy, we still walk comfortably. And it's very heavy, what we'll do is we are compensating. So if it is optimally loaded, we will get the activation. If we
Agreed, sir.
overload,
Yeah.
it will.
There was one more thing Parthav sir has added. So if the patient is not comfortable in sitting position, you have to change the position. Now why there is a requirement of change of position? Because you want more comfort for the patient. You don't want any resistance in early phase so that he can initiate the movement. The priority is initiation of movement and activation of muscle, not the strengthening part. That is why we are changing the motion, we are changing the position to make him comfortable. जितना patient comfortable होगा उतना उसके लिए वो movement easily करना ज़्यादा better होगा. And that's how we can train the patients. Like we can go for the supine position or lying position or sideline position. We can continuously train them in the same position and progressively we can change the position, and that's how we can train, right sir? Right. Yeah.
The idea is mainly to improve the quality movements.
Improve the quality movements rather than so early goal of rehabilitation is mainly neuromuscular coordinations rather than the strength, as you say. So if pain is there, if you're sitting already against the gravity, that won't help you. As I said, deltoid activation are more as you raise your spine, as you increase your spine's angle. So that's what the idea mainly.
So there is one more concept we are using for short lever arm and long lever arm. Usually when we treat ACL patient, so बहुत क्या होता है कि when you try to tell them after following the Instagram exercises and that YouTube video की वो usually वो use करते हैं कि you should sit in long sitting position and you start telling them to raise the leg. So it is more of straight leg exercises, right? Now straight leg exercises are long lever exercises for quadriceps, if I'm not wrong. And the same way, if you tell the patient in phase 1 rehabilitation, tell the patient to perform those exercises in high sitting position first. So you're working on VMO and vastus medial, vastus lateralis more early. So by making them more active isometrically, आप बाद में जब वो चीज long lever arm में कराओगे ना, वो उसके लिए easy हो जाएगा. Because he has already activated the muscle in high sitting position and this is short lever arm. So I think the
I
choice
just
of
beg
exercise. Yeah.
I just beg to differ. Theoretically, what you're speaking is right, but when we say quadriceps is working in against long lever with SLR, rather quadriceps only the rectus femoris has to work. Rest of the quadriceps are not active with hip flexion, and if we that is what initially we go with SLR with support just to activate the quadriceps. But just I'll get back to the shoulder back.
Yeah.
Thank you.
So the next conference topic is already decided. That is knee rehab.
So may I have one student, physiotherapy student, please? I will not have you. I cannot have you because you are overqualified.
I'm a student only.
You are overqualified for the job.
Student.
No, actually, yes. The purpose is you know lot many things. I mean, you know the
Yeah, I
implementation.
understood.
Okay, so suppose you have to perform, so we will go with simple scapular stabilization exercises which you all have been doing. Can you show some scapular stabilization exercise? Don't worry if you are wrong, there is nothing going to happen. You are absolutely safe and all are going to appreciate you for coming over here. Just show. Scapular stabilization exercise. Okay. Don't think what you don't know. Do what you know.
Just focus on what you know and just do
તમે
it.
શું કરાવો છો patient? હા કરો. Repeat the repetitions. Okay, so this is what we usually do. Now let me give you the correction. Okay, relax. Just follow and perform the same thing. Perform the same thing. Do you think any change? What happens? શું થયું? क्या efforts क्या આવ્યા? When I did, okay, you again do it. See, this is for all of you to try out. એટલે બધાને અહીંયા
Everyone
બોલાવી
please try out.
બધાને અહીંયા બોલાવી ના શકાય. So when you're doing this, what's happening? And then, okay, relax. So I'm this. Now do. Now what is happening? You are going to make out? No. Do you think there is more better contraction over here than what you? Huh. So that is what I say. It's implementation which is important. So usually what we tell the patient to do, અને કદાચ ઘણા બધા ફિઝિયોથેરાપી ક્લિનિકમાં એવું શક્ય છે. I don't say you do it, પણ એક થેરાપિસ્ટ હોય ને 4 પેશન્ટ હોય તો what we do? Okay, તમે આ કરો. Because we have other patients to look after. So you do this, and what the patient is doing is, you see my shoulders, right? What he is supposed to do is, so you just do this thing, and you see your scapular activation. You just pull your shoulders back, and you see your scapular activation. Do you think there is a change? So exercises are, it's not that how difficult exercises we do. It's important how efficiently and how qualitatively we perform the exercise, right?
Okay.
So scapular stabilization, retraction of the scapula as the first exercise was. Okay, so we can start with these exercises. We can start with this, we can do these exercises initially. We can do these exercises in standing also, like simply. We are retracting the scapula. But one disclaimer over here, or sorry, one important point to be noted. It's a close kinetic activity most of the times. So when I say do this, I am engaging along with my core muscles, my hip muscles, all the muscles which are required to work. If I don't do, then because as sir was showing, कि पाछળ ball મૂક્યો તો posture correct થઈ ગયું. That was a feedback. Say, so if we activate the muscles, even the posture, he said, you just work on this is automatically corrected. અહીંયાથી correction આવશે તો અહીંયાથી આવી જ જવાનું છે. પૂરેપૂરું નહીં આવે તો at least 50% તો minimum આવશે. So we are engaging all those muscles. અને shoulder rehab ની વાત કરીએ તો for when we go for advanced rehab, okay, I'll come to this point later on. Okay, so we are engaging these muscles over here, so we can retract simple retraction activities. Okay, this can be done. It can be done. તમે જ્યાં બેઠા છો ને, મેં ટ્રાય કર્યો એવું થાય છે, તમારા ખુરશીના હેન્ડલ છે ને એને ખાલી જેન્ટલી પુશ કરો. ખુરશીના હેન્ડલને જેન્ટલી પુશ કરો, એકદમ આરામથી, જોર મારીને નહીં, एकदम ધીરેથી પુશ કરો. and do you think your scapular stabilizers are getting activated? एकदम lightly push કરવાનો try કરો. No more effort. एकदम lightly, just do this. So you will be able to activate. You can activate the shoulder like holding something. આ લેવલમાં જે આવતું હોય આપણો હાથ પહોંચે ત્યાંથી. What I'm trying to do is ઊંચકવાનું નથી, ઊંચકવાનો ખાલી પ્રયત્ન કરવાનો છે. એટલે એક્ટિંગ કરવાનું છે, ઊંચકવાનું છે. So what I'm doing is, even this will retract the shoulders. Okay, so these are retraction and stabilization of the scapula. So if you have got good strength and required, we can even lift the, so that is advanced we are going for, but even simple activation techniques would work. Okay? So scapular retraction, prone scapular retraction. Okay, prone scapular retraction can be done in prone line. can do again the
So this is the proscapular retraction.
this can be done, and otherwise even if you just keep like this, and what you can do is the minimal of effort. You could see the scapula girdle retracting.
Can you see the scapula girdle retracting?
So these are the minimal of the efforts. એટલે activation માટે જે કરવાનું છે ઓછામાં ઓછી તાકાતમાં પણ થઈ શકે. See, all the exercises not necessarily બધાને બધી જ પોઝિશનમાં બધી જ exercise થાય. કોને ક્યાં લાગુ પડે છે એ you people are wise enough to decide that. I'm just highlighting. Okay. So supported scapula setting, inferior line low row. Okay. So we can go with low row as I said. This is a kind of low rowing. Okay. Rowing is this. This is simple rowing, low, just activation of the muscles. Yes.
Then talking about the criteria to progress from maximum protection phase to the moderate protection phase, and the criteria are as follows: there would be minimal pain around the shoulder joint, then no sense of apprehension about instability with active motions, then a well-healed incision, and the shoulder passive range of motion of shoulder flexion could be 90. If it is more than 90 degree or 90 degree, we can progress to the next phase. Then the shoulder passive range of motion in external and internal rotation in the scapular plane could be 20 degrees. Then the palpable muscle contraction, as sir said, that when the patient is doing the isometrics, then we should keep our hand and check for the palpable contractions in the scapular and shoulder musculature.
So palpable muscle contraction initially can be started with as simple as activity as a ball squeeze, or if nothing, okay, squeeze my hand, and we check for the contractions. Okay, he is able to generate the contractions over here at the shoulder muscles. Okay, that can also be initiated.
Now moving forward to the moderate protection phase, it lasts from approximately from 4 weeks to 9 weeks, and we have divided into two parts because of the complexity of the exercises. Now talking about the moderate protection phase 1, then starting from 4 to 6 weeks post-op approximately, then the goals are to regain full range of motion, then to continue protect the surgical repair, reduce swelling and minimize the pain around the shoulder joint. Then we should gradually focus on increasing the shoulder passive range of motion, and we should notice the substitution patterns with the active assisted range of motion, and we should educate the patient and we should give realistic goals. Now talking about the precautions, talking about the immobilization, we should start now weaning off the sling. Like after this phase, like no immobilization should be required, and we should redirect with the surgeon according to that. And the other precautions are no lifting of heavy objects and still no supporting of body weight with hands. Now talking about the intervention, sir.
So with the sling, initially what we could start with after a week or 2 weeks time, when the person is still, the shoulder is in sling, and suppose he is an athlete, or even if not athlete and is able to perform, what we can try out is
To work on the
using the
kinetic
shoulder
chain.
in sling. Why are we doing this? Yes.
We are just engaging lower body with
Yes.
the scapula.
Yes, when I am doing this, this is a kind of DI pattern you will be able to make out, okay, which you will be doing in advanced rehab for through athletes say like this. The same thing with in the maximum protection phase, we are not moving the shoulder, but this is a key part. The trunk and the hips, lumbopelvic hip complex, they are key support. And as per one study, if they reduce their support, then by about 20-25%, then the shoulder will have to work 34% more to generate the same kind of energy. And unfortunately, I remember about Jasprit Bumrah sir has met him, and we once before in a CME also I have spoken about that he runs with a very short run up. The acceleration in the fast bowler, about 60% of the acceleration comes from the run up. So because he has short run up, he has to use more of the trunk and the shoulder muscles to generate the pace he is able to, and that is why his back and his shoulder are more vulnerable, and unfortunately that's why we are missing him out of the team since a long time. Okay, so activation of these muscles આર વેરી ઇમ્પોર્ટન્ટ. એટલે આપણે શોલ્ડર રિહેબ કરીએ છીએ તો આ બધું રિહેબ જોડે ચાલે જ છે એવું માનીને કરીએ છીએ, અત્યારે કરી નહીં શકીએ. બટ યુ હેવ ટુ કીપ ઇન માઇન્ડ દેટ when we go to advance, we are still working on these components also, okay, not only on the shoulder.
અને જેમ રોહન સરે કીધું કે આપણે અર્જુનને માછલીની આંખ જોઈ હતી એવી રીતે આપણે કમ્પ્લીટલી શોલ્ડર અલોંગ વિથ ધી લોવર બોડી કોર બધા ઉપર ફોકસ કરવાનું, ખાલી શોલ્ડર ઉપર નહીં. વી હેવ ટુ ડુ અ હોલિસ્ટિક અપ્રોચ.
Okay, so wash cloth press is in the lying position. You will hold a cloth, a small towel, and you will lift up, say 90 degrees, and you will squeeze. Okay, so these are simple exercises to increase the range of motion and to activate the muscles. I'm not going into deeper aspect. Seated table slides, again what he has demonstrated earlier, okay, with the Swiss ball or onto the plinth or onto the table. ટેબલ પર પણ આપણે કરી શકીએ. પેશન્ટ ખાલી બેઠો હોય કે ઓફિસમાં પણ હોય, he can still attempt this. One important aspect I would like to mark out over here is we need to imbuild the exercises in day-to-day routine. એ બહુ એક કોમન કમ્પ્લેન છે, ટાઈમ નથી મળતો. So how can we have a solution for that? Because we want the patient to work, અને પેશન્ટ મેં સવારે કસરત કરી હતી પછી આખો દિવસ ટાઈમ નથી મળતો. So if we incorporate the exercises in day-to-day activities, like if someone is on in an office job, ટેબલ તો લગભગ કદાચ હોય મોટા ભાગના પાસે, so they can perform these activities, okay, so that can be encouraged. Salutes, okay, supine punch. Now this is important to activate the serratus anterior. So wrapping around the scapula, so we can go for this supine punch or we can go for this kind of punches depending upon the requirement and the involvement of the patient. Serratus anterior activation can be achieved. In the initial phase, we can use flexibars, okay, to activate the shoulder muscles, the stabilizers, scapular stabilizers and the rotators, both can be if you have used. એટલે ઘણા બધા સ્ટુડન્ટ્સને આ ઓપોર્ચ્યુનિટી કદાચ ના મળી હોય, when I say if you have used, બાકી બધા તો all are learned people and will know better, but I emphasize students કે જે પણ ફેસિલિટી છે એનો યુઝ કરવો તમારી ત્યાં, so you know what it is and how it is working, okay. So going into, I am moving out of phase, હજુ rehabilitation protection phase માં જાવ છે, but from here in I am just progressing what all we can do, okay. From here the squeeze, what I can do is, so okay, rotate again, engaging the rotators over here. You can make out the external rotators, this can be done, okay. And later on with the same thing, what I can start with is આ પ્રોગ્રેશન બતાવું છું આખું. And if you are progressing, so when it comes to here, what I have done is I have increased the lever arm, okay, and that will have a lot of effect at the shoulder joint. આ લેવલે કરવું ને આ લેવલે. Anybody wants to try? Anybody wants to try?
Anybody? Please come forward.
I mean, you will see the difference in the engagement of the muscles, okay, when you do this. So this is the progression. We can go up to this level, right? Same way, we can use vibrating pole. So starting initially in restricted range of motion, we will try to, now this is a very good activity like the flexibar, and this will encourage the recruitment of the muscle fibers. So now this is, if I try to move, it's not going to move. Okay, it's not going to move because I'm moving it. It will move only and generate a strong co-contraction of the muscles at the shoulder joint. So when I'm doing this, initially, okay, then, so I'm engaging the rotators of the shoulder joint over here. I'm rather recruiting all the muscle fibers, right from the hip extensors to the core, all the muscles are getting activated. So from here, okay, I can do this, changing the grip up and down, will change the muscle recruitment in each of the shoulder. We can do this. We can start initially in this position also. Okay, then we can progress further. the more vibration you create, the better recruitment you are recruiting your muscles, the shoulder muscles. Anybody can take a try if they want. And if they want to see how it works, it will really work wonderfully. And progressing further with the same thing, I can go to the same way activating the retractors. These are little weak, so I am not able to do it very strongly. Fine. So then progressing further for an athlete's sake, for throwers and all, we can. So this is a progression we can do with this flexi bar or bipole. એટલે એક કોન્સેપ્ટ એવો છે પહેલા ક્લેરિફાઈ કરી દો કે we usually go with close kinetic chain activities. આ પ્રોગ્રેશન મેં આખું બતાવી દીધું એટલે આ લેટર આવશે in the later phase, but usually we focus early on into close kinetic chain activities.
Now the criteria to progress are the 115 degrees of shoulder active range of motion in forward elevation, 135 degrees shoulder passive range of motion in forward elevation, 50 degrees of shoulder passive range of motion in external and internal rotation, that too in the scapular plane, then 45 degrees of shoulder passive range of motion external rotation in 90 degrees in abduction, and the pain score should be less than 2 out of 10, and there would be no complications with the exercises described before. Then the moderate protection phase advanced, then I mean that the second part of the moderate protection phase, it lasts from around 7 to 8 weeks post-op. Then the goals are to not stressing the healing tissue as discussed earlier, then gradually increasing the shoulder passive range of motion. Now we can progress to advanced rotator cuff strengthening, then improve the periscapular strength and improve the dynamic stability of the shoulder complex. And the precautions would be no lifting of heavy objects more than 5 kgs. And
Yes. So again going to the basics, when we start with close and when we are at 90 degrees, little space constraint, but I don't think there will be better place than this to show. So what we can start with is, okay, we are loading the muscles. Then we can add the alterations. We are changing the direction, up, down, left, right, in, out. Okay, rotations we can add. We can be started initially also in this phase, the simplest possible. Then from here in only we can go for push-up plus or serratus anterior activation. Okay. Herein the body has to be in good alignment so as to get a better effect. So from this I can reduce the inclination. I can increase the inclination and push up plus again in inclined position. From therein I'll go further down. Okay, the progression of this can be made. So I am going with all the aspects we can progress onto with one particular activity. क्या શું લાગુ કરવાનું એ સિદ્ધાંત આપણે કહે છે. So I can do this, I can do this, I can with the soft pad. The same progression can be done with the both the things we can use. This would be little, this is firm but small base. So again push up plus we can do serratus anterior activation. So we are activating the rotators over here. The same thing can be done on the Bosu ball. Okay. So all these activities can be added up as a progression in the closed kinematic chain.
Now the criteria to progress from moderate protraction phase to the transitional phase are the 155 degrees of shoulder passive range of motion in forward elevation, 145 degrees of shoulder active range of motion in forward elevation, 65 degrees of shoulder passive range of motion of external rotation and internal rotation in the scapular plane, and 75 degrees of shoulder passive range of motion external rotation in 90 degrees of shoulder abduction. Now talking about the transitional rehabilitation phase means transitional rehabilitation phase goes from moderate to minimum protection phase के बीच वाला phase, and the time duration are the approximately 9 to 11 weeks post-op, and the goals are, as we said, that do not overstress the healing tissues. Now gradually increase the end range, shoulder passive range of motion, and now we could work on the improving the dynamic shoulder stability and progress to the advanced rotator cuff strengthening, and the importance of working on the scapular stabilization and rotator cuff strengthening, as we all learned earlier today, like the force couple. Then the rehabilitation goals and these are the exercises.
So from close kinetic, we can move on to open kinetic chain exercises. So for the throwers, starting with minimum this, okay, we can progress, adding the load. We can make the task more difficult, keeping one limb onto a bosu ball or any soft surface, so that will add up to the requirement of the lower limb as well as the trunk musculature and will facilitate greater recruitment. So this can be done for a boxer, okay, for a overhead activity athlete.
Involving abduction and internal rotation.
So these all, there are lot many exercises, are lot many. We can build up as many as we want. We can progress in this way, and then moving on to the okay. So these are different ways we can perform the activities. So hopefully you'll be able to make out from this. Right? Okay, so this will come in the initial phase, say in the moderate protection phase. Maximum to moderate protection phase will be taking up these activities. Okay, so when the more advanced, the same things can be repeated anyway with free hands,
YBW exercises.
then with say wait. So again, performing the same activities with the weight, we can use the dumbbells, we can use any other weights, sandbags, weight cuffs, okay? This all can be performed, increasing the difficulty level, further progressing. I would want you to perform exercise, almost everyone. Will you do it?
Will you do it?
Exercise set करसो. Most of the people have got protected shoulders. Most of the people. And I take the privilege. મારે કોઈ પેશન્ટને બતાવવાનું હોય ને તો હું જોડે જોડે કરી જ લઉં કે આવી રીતે કરવાનું છે. એવું બતાવવામાં હું કરી લઉં કે મને ખબર છે કે આ કરવાથી મને ફાયદો થાય છે. I want you to repeat with me. It's simple exercise, but you see the effect. અત્યારે તમને કેવું લાગે છે, તમારી ગરદન કેવી છે અને પછી કેવું લાગે છે. Engage the core. And what mistakes are elbow straight, thumb pointing backward. We are not going down and coming up. From slightest of, say we are at 170 degrees and then we are going to 180. Engaging the core. Arms not very wide apart. Muscular weakness છે તમને બેક પર નેક પર પણ સ્ટ્રેસ આવી શકે છે બરાબર છે. One is this. Do as many as repetitions you can do. અને ગણો કેટલા થાય છે. So that would be your base. So if you want to start from tomorrow, you know that today you did this many. સરે જેમ કહ્યું એમ કે ફોટો પાડી રાખીએ, વિડીયો ઉતારીએ તો આપણે ફોલોઅપમાં ખબર પડે. So you mark out the count. Second is palms facing each other, asymptotically lowering, gently, एकदम धीरे धीरे to 90 degree, not more than, only to 90 degree. Palms facing each other, एकदम धीरे धीरे करवाना है. કેટલું કરવાનું એનો બહુ સાદો જવાબ છે અને આ બહુ કોમન ક્વેશ્ચન હોય પેશન્ટનો કેટલું કરવાનું એન્ડ ધી આન્સર ઇઝ વેરી સિમ્પલ તમને માફક આવે એટલું એટલે વધારે કરવા જઈએ તો તકલીફ પડે વન્સ વી એસ્ટાબ્લિશ ધ બેઝ ધેન વી કેન એડ અને એડ કેવી રીતે કરવાનું તો અગેન આઈ સે વધારવું કેવી રીતે ઇન ટર્મ્સ ઓફ પેશન્ટ જમવામાં મીઠું ઉમેરીએ એટલે કદાચ પ્રોગ્રેશન થોડું સ્લો થાય એવું લાગે કે ફાસ્ટ આવતું પણ જો ઓવર થઈ ગયું તો જે લેવલે પહોંચ્યા છે ત્યાંથી સાપ સીડીમાં સાપ ગળી જાય તો નીચે આવી જાય એવું થાય બરાબર એટલે જમવામાં મીઠું ઉમેરી એ રીતે પ્રોગ્રેશન કરવાનું થર્ડ ઇઝ અગેન હિયર નો ફોરવર્ડ ફ્લેક્શન ફ્રોમ ન્યુટ્રલ retract elbows and shoulder in the same line engage the core if you don't engage the core what will happen is it will be like lumbar lordotic aggravation. Engage the core. And the most beautiful of the exercise is now.
Your favorite.
That's what I said, the most beautiful of the exercise. આટલી જગ્યા જોઈશે એટલે એક જણ કરી શકે કદાચ બે ત્રણની વચ્ચે અને પછી બીજા ટર્ન લે because I am sure you won't be able to carry on for a long time. આપણે પ્લેન અને એક્સિસમાં એક્સિસની ડેફિનેશન ભણીએ ને an imaginary line about which movement takes place. So this is the imaginary line and the movement has to take place at this level only. એટલે હાથ આમ થઈ જશે તો એક્સરસાઇઝ બહુ ઈઝી થઈ જશે આમ થઈ જશે બહુ ઈઝી થઈ જશે this is the axis and the movement has to be there only. What I am going to do is making 8 આપણે RTO માં ગયા હોઈએ તો આંટડો પાડ્યો હોય ઇંગ્લિશનો બસ એવો આંટડો આપણે અંગૂઠાથી બનાવવાનો છે you see this but the હાથ આગળ ના આવવા જોઈએ બીજી ટ્રીક શું થાય છે what you can do is see this is trick આ ટ્રીક કરશો તો તમને એવું લાગે તો બહુ ઈઝી છે if you are moving the wrist or if you are moving just performing supination pronation if you engage the shoulder rotators this is a very good exercise to activate the rotators and the scapular stabilizers આટલું કર્યા પછી તમારા શોલ્ડર રિટ્રેક્ટ ના થયા હોય so these are the exercises we can progress in the clinical setup or even on the field માં આપણે engage રહીએ or we can teach them the couple exercises એટલે પ્લેયર બધાને જરૂર હોય if I am holding and another is performing so I am also exerting એટલે બંનેનું strengthening થવાનું જ છે.
Now criteria to progress to the minimum protection phase and the criteria are the full and pain free passive as well as the active range of motion of the shoulder joint. Then the substitution pattern should be minimum and perform all exercises demonstrating symmetric scapular mechanics as Ronak sir said and the Abhay sir said that we should check for the scapular asymmetry right in the examination part. Then while performing these exercises we should pay emphasis on that the scapular mechanics are proper and we should compare. And the pain criteria for pain is the minimal. Then talking about the minimum protection phase, it begins around the 12-week post-op or as late as 16 weeks. And now we can move forward to the PRE as the progressive registered exercises. And we should start working on the plyometric as well as we can also apply taping and we could do the at least could do the exercises.
So plyometrics can be performed the stretch shortening cycle exercises if I do here દેખાય છે so I can start with the easier one I can increase the speed the same thing to increase the difficulty level okay this can be done using the medicine ball we can perform these all exercises This is again a very good exercise for the rotator cuff muscle, the rotators of the shoulder. You can see the rotation taking place at the shoulder joint. So this can be performed with a simple ball, smiley ball, then you can go to a tennis ball, then go to a cricket ball, and then to a medicine ball. There are certain more advanced exercises which we can take up. એટલે જ્યારે પ્લેયરને બેક ટુ ફિલ્ડ મોકલવાના હોય ત્યારે આ એક્ટિવિટી થવી જરૂરી છે. અધરવાઇઝ વોટ હેપન્સ વી સી ખેલ મહાકુંભ બહુ સારું ચાલે છે અને બહુ બધા પ્લેયર્સ યંગ એજ પ્લેયર્સ કમ્સ ટુ અસ ઇન્જર્ડ અને જેમ સરે કહ્યું હતું કે પેન સ્કેલ 5 or 6 out of 10 નહીં રમવાનું. કોઈ સાંભળતું નથી સાહેબ. યા બીકોઝ એ નહીં રમે તો એને સિલેક્શન નહીં થાય, સિલેક્શન નહીં થાય આગળ સપોર્ટ નહીં મળે. એટલે દુખતું હોય ને તો પણ રમીશ, જ્યાં સુધી રમાશે ત્યાં સુધી રમીશ.
કોચ બી કહેશે કે ના મારે આ પ્લેયર જોઈએ સર, ગમે તેમ કરો મને ઠીક કરી આપો.
એટલે I have seen and I have seen people, I know one very close contact, સરને પણ કદાચ ખબર હશે, and she had a shin spleen. અને મેં કહ્યું કે હવે દોડીશ તો પગ તૂટી જશે. તો મને કે આ રેસમાં હું દોડીશ ને ગમે તેમ દોડીશ ને તો મારો નંબર પાકો જ છે કે એટલે મારે આ મેરેથોન તો દોડવી જ છે. અને she ran and as it was પછી stress fracture. So it's very difficult for the sports person to understand themselves also, being a physical therapist also. એવું નથી કે સમજણ પડતી હોય તો ના કરીએ. We have examples of orthopedic surgeons who runs having induced stress fractures twice, thrice. એક વખત નહીં 2 વખત થયા હોય એવા orthopedic surgeon પણ છે. એટલે there is a lot of psychosomatic control required onto the sports person side. So if you want to progress, so this is a medicine ball throw. We can start with a double arm throw. પહેલા બે હાથે start કરી શકીએ, and then we can go with a single arm throw. The dominant side being used. This is to activate the latissimus dorsi and the lower trapezius. Lower trapezius work is very important to counter the trapezius, upper trapezius in providing a force couple. So it is important pull-ups karva karta to start with this. If you are doing pull-ups with this way, it's not going to help. So it's important we activate the lower trapezius, we activate the latissimus dorsi, that is the depressor, and then we can progress. This is again activation of the serratus anterior. If you see the punching action of the serratus anterior with the medicine ball, so you get into the position, you are strengthening the serratus anterior, and these are all required in advance rehab before sending the patient, the athlete to the field back. આ લેવલ પર rehab કદાચ થતું નથી હજુ. We are thankful to Indian cricket team. I am particularly came because Virat Kohli worked with the fitness and then they set the standards. The Yo-Yo test ma we want 17:1 level. We want fast pace bowler to run 2 kilometers in 8 minutes. We want spinners to run 2 kilometers in 8:30. ये standard set થયા તો improvement fitness level નું આવ્યું. And to the extent that last year probably against T20 against England, there was a Rahul Chakravarti probably, or two players were selected for the national team to play against England. That is the dream, I think, for every player to play for the country. They were selected and they were ousted because they did not meet the fitness standard. Another example, if you would have, I think, Sarfraz of Mumbai, he is counted to be a very good player. He is not being picked up because he is not physically very fit. So the fitness standards being raised, it's good in terms કે નીચેના લેવલથી એ ઇફેક્ટ આવશે કે આ લેવલ પહોંચવા માટે આ ફિટનેસ જોઈએ છે તો આ મહેનત કરીને જ જવાનું છે. નહીં તો શું થાય, ક્રિકેટ રમવું છે ને હું બેટિંગ કરીશ.
Now the criteria to progress from the minimum protection phase to the return to sports phase are the full pain-free passive and active range of motion, and then joint position sense with less than 5 degree of margin of error, and the as compared to the uninvolved arm, the strength of the affected arm should be greater than 85%, and the external and internal rotation ratio should be greater than 64%, and the scapula, then there should be no scapular asymmetry, and the close kinetic chain upper extremity stability test, Males નો criteria છે more than 21 taps and female no greater than 23 taps.
So it is that tap is we can make it more harder by putting it to shoulder tap.
તો આ થાય પછી જ એમને રિટર્ન ટુ પ્લે એમને અલાઉ કરવું જોઈએ. થોડી ટ્રેનિંગ કર્યા પછી ટ્રેનિંગમાં બી જો ના હોય એના પછી we should let them return to play. એના પછી talking about the management of
One more
GIRD.
thing before return to play. Sorry. So it's not only fitness, it's skill also. It's hand-to-eye coordination. If I am playing a baseball, I am playing cricket. Ball આવે છે મને દેખાતો નથી એટલે hand eye coordination એટલું strong નથી એમ કે ball આવે છે એ વખતે I can move, then what would happen is it will hit me. So that is also important. So this is a reaction ball, and this is to improve the reaction. So it will improve the reaction technique of the person, and that is important to prevent injury. Why this is important? ખાલી રમવા માટે નહીં, injury prevention માટે this is કેમ કે મેં કહ્યું એમ ball આવે છે, if you cannot move at the right time, it will hit somewhere else. So we need to improve the reaction time of the athlete. We need to improve the hand-eye coordination. So we can use this also for that.
Now talking about the management of GIRD.
So glenohumeral interrotator deficit as we saw earlier. So this is a kind of atraumatic kind of instability which is being induced because of sports. So very commonly the posterior capsule will be tight and you can stretch with the slipper stretch. Okay, this way we can do it. We can also stretch by the side of the door. This way we can stretch the posterior capsule. Okay, we can also induce
For the posterior capsule.
We can go for foam rolling, release the muscles, infraspinatus, latissimus dorsi. This can be released so that the muscles are free and we can gain the ring more easily.
Thrower stand program.
So basically we have covered thrower stand program is a thrower or any overhead athlete has to undergo this kind of rehabilitation, and once he completes this program, then only he is eligible to go back onto the field. So basic rotator training, we saw external rotation, internal rotation, being in neutral position, strengthening the maximum protection phase. Then from neutral to abduction external rotation, from increasing speed in abduction external rotation to activities, functional throwing and accelerating, what we mentioned over here with the medicine ball and ultimate focus on eccentric strength of the external rotators. What we did, this repetitive cycling, plyometrics, okay. Focus on the acceleration of the posterior shoulder muscles. That is again they will require the eccentric loading so as to control, to develop the control, and ultimately focus on stretch shortening phase of throwing. That is the plyometric activity what we saw. So if this program is met right from the beginning, if he fulfills all these criteria, that is he can go for the plyometrics, then only put the player back into the field. It is very difficult as a therapist. કેમ કે ultimate call coach જ લેશે.
પહેલા ટ્રેનિંગ કમ્પ્લીટ કરે પછી કોમ્પિટિટિવ ફેઝમાં જાય. તો આખી લાંબી જર્ની છે and we have to be there with the athlete as a supporting as a member of the sports science team. And talking about the return to play criteria, I would summarize it quickly that there would be no little to no pain on a self-reported NPRS scale, then the full range of motion, and the side difference of GIRD should be less than 20 degrees, and strength should be as compared to the unaffected side, and it should be more than 75%, and there should be symmetry, and the functional ability की बात करिए तो seated medicine ball throw test, wire balance test, endurance test for the rotator cuff, and he or she should have completed the thrower stand program. Thank you.
Maybe one of you in future can get into a system of policy making. So wherein I would suggest if you ever anybody gets a chance to get into the system where you are in a policy making position, in tennis there is a particular way of protecting the ranking. એટલે કોઈ પ્લેયર ઇન્જર્ડ થાય, માનો મારો વર્લ્ડ રેન્કિંગ 5 છે ને હું ઇન્જર્ડ થઈ ગયો, તો દે વુડ ફ્રીઝ માય રેન્કિંગ કે 6 મહિના સુધી કે 8 મહિના સુધી હું પાછો ના આવું ત્યાં સુધી મારો રેન્કિંગ 5 રહેશે, though I am not. But because I was fifth and I got injured and I got out, to protect my position and to encourage me, that is done in tennis at world level. So if we are into a policy making position anytime in future, we can plan out that we can provide such security to lower grade. Lower grade means young athletes જે જો હાઇલાઇટ નથી થયા લેવલે આવતા તો ટાઈમ લાગે, પણ નીચેના લેવલે જો આ સપોર્ટ મળે ને કે તું ઇન્જર્ડ છું વાંધો નહીં, હવે તને એકચ્યુઅલી ખેલ મહાકુંભ પ્રોવાઇડ સપોર્ટ, મેડિકલ સપોર્ટ તો આપે જ છે, બટ સિક્યોરિટી નથી એમ, એટલે તું આઉટ થઈ ગયો તો પછી આવતા વર્ષે સિલેક્શન તારું થશે કે નહીં ખબર નથી એમ. સો ઇફ ધેટ કેન બી ડન ઇન અ લોંગ રન, ધેટ વુડ હેવ ધ ગોલ. એટલે 2036 નું ઓલિમ્પિક અમદાવાદમાં રમાવાનું છે, એટલે રમાડવાનો પ્રયત્ન ગવર્મેન્ટ કરે છે. જો આપણને મળ્યું તો આપણો એવો ગોલ રહે કે આજથી 13 વર્ષ પછી કોઈ આપણો તૈયાર કરેલો એથ્લીટ હોય, સ્પોર્ટ્સ પર્સન હોય ને ત્યાં પરફોર્મ કરીને આપણા માટે ગોલ્ડ જીતે, then we will be proud of. Thank you.
So you rocked the stage. You are truly a rock star. Any questions for sir?
I have a question, sir. According to you, GIRD in itself is a problem or a pathological finding, and should it be addressed alone or not?
It's a atraumatic developed instability, and no condition should be addressed alone in singularity. I mean, when someone is developing any problem, there will be other associated. There is a concept of biotensegrity. You will be aware of. I often show the model of biotensegrity to my students. So biotensegrity is basically આપણા muscles અને bones છે, જો muscles કાઢી લઈએ bone માંથી, તો what will happen? The bone structure will collapse. Likewise, if there are no bones and only muscles, or if any muscles, like, because there are some working, overworking, some not working, so not addressing similarity, we will address the person.
My question was in terms was, if we say that it is internal rotation deficit, should our focus only be on achieving the deficit of internal rotation or not?
Can I sir elaborate what he's mean that એવું કહેવા માંગે છે કે ઇન્ટરનલ રોટેશન જો ડેફિશિયટ હોય તો આપણે એડ્રેસ કરવાની જરૂર, because when we screen the athletes and especially when you dealing the athletes with the unilateral game where they use the one side more and the other side not, so we found 90% of athletes have a deficient internal rotation, more than 90%. But if it is not asymptomatic and not symptomatic, so what should be done that in that case?
Yes, very good Raja question. Sorry I got it late. Thank you, Parthabhai. So I will say there are numerous athletes performing very well at the world level, and we could see what we speak about, like he was mentioning કે posture abnormality છે, deviation છે, પણ વર્લ્ડ લેવલે મેડલ પાડે છે એવા બહુ બધા એથ્લીટ છે જેમના આપણને જોઈને એવું લાગે એઝ અ બાયોમિકેનિક્સ, એઝ અ ફિઝિયોથેરાપિસ્ટ કે આના પોસ્ચરમાં પ્રોબ્લેમ છે, આની મૂવમેન્ટમાં પ્રોબ્લેમ છે, આમાં પ્રોબ્લેમ છે. સમરથ को नहीं दोष गुसाई. So till he is performing well, whatever you advise, you cannot pull it, don't do. Yeah, you have to let do, but the measures has to be taken along with so that doesn't progress. Because correction is a difficult thing, but measures there is in terms of stretching, in terms of strengthening, has to be taken in prior or simultaneously the condition doesn't progress. Because maybe હું મારા છોકરાઓને મારા સ્ટુડન્ટ્સ કહેતો હોઉં છું કે કોઈ આમ ચાલતું હોય કે કોઈના પગ આમ હોય તો ઘણા બધા એવા છે કે આખી જિંદગી કાઢી નાખે છે, કોઈ કમ્પ્લેન નથી. એટલે આપણે એવું નહીં આને પગ વાંકા છે તો આને પ્રોબ્લેમ થશે જ એવું કહી ના શકીએ, પણ પગ વાંકા છે તો શક્યતાઓ છે, તો એ શક્યતાઓને ધ્યાનમાં રાખીને એ વધે નહીં અને કરેક્શન થાય એના મેઝર્સ તો આપણે લેવા જ પડે. Have I answered your question satisfactorily?
Like the term GIRD was coined by a specific author.
Yes.
And in couple of years, in recent time, he himself came publicly and said that we shouldn't think of it as an issue.
Yeah, that's what I said. કે postural deviations હોય, what we see, આપણે જે ભણીએ છીએ કે pathological છે, winging ની વાત કરતા હતા, તો single hand activity, overhead athletics, બહુ બધા ટેનિસ પ્લેયર છે જેમાં dominant side માં winging છે અને એ રમે છે ને સારું રમે છે, તો આપણે કહીશું કે રમવાનું બંધ કરી દો, તમારું winging થાય છે, પ્રોબ્લેમ થશે, તો આપણું સાંભળે છે?
And Karta, it is more of a game specific adaptation.
હા, adaptation comes up, but that adaptation can cause a problem possibly, not definitely.
Like the way they studied that GIRD. So when you start the assessment, na, because of a repeated practice in the same pattern over a very long period of time, that is their new normal.
Yeah.
And it can never come down.
Yeah, that's what I said. It can never come. We don't want to correct it, but we take precautions so that it doesn't progress. As you said, micro-traumatic instability. So that is going to develop micro-traumatic instability in the long run, maybe. થશે કે નહીં ખબર નથી, પણ ચાન્સીસ છે કે વારંવાર there will be bone loss possibly in overhead athletes who are accustomed to such activities for a long period of time. તો એ લોસ થવાનો છે, લોસ તો ભરપાઈ થવાનું નથી. તો એ પ્રોબ્લેમ થઈ શકે એવી ગણતરી રાખીને એને કંટ્રોલ કરવાનો પ્રયત્ન કરીએ, but we don't say winging of scapula, that is a problem, you come back, come for the rehabilitation, then go for, that's not possible.
So basically હવે recently મારા હિસાબથી articles પ્રમાણે, so they said rather than just looking at the internal rotation, we should look for the whole arc, whether it is gain is there or not. Second thing is why we avoid to gain the internal rotation certain times, because there are few athletes who start early, like at the age of 8 and 9, so there is a morphological changes, humeral head, and which we can't do it through the exercise. So there are harm of doing that. So that's what we need to avoid. We need to wisely choose where to avoid, because one of the cause of impeachment is internal rotation. So do we really need to address that or not? That is main important when you looking at in your rehabilitation. So that is the main question from સૌ બેઝિકલી કે આપણે બધામાં જ એડ્રેસ કરવું જરૂરી નથી, બટ સર્ટેન કેસમાં આપણે એડ્રેસ કરી શકીએ. બટ જો એક્સટર્નલ રોટેશન ગેઇન હોય તો ઇન્ટરનલ રોટેશનને છોડી દે, કારણ કે મોર્ફોલોજીકલ જો એ જો હ્યુમરલ હેડ રેટ્રોવર્ઝન કે કંઈ હશે તો આપણે ઉપરથી વધારે ઇમ્પીચ કરી રહ્યા છે અને વધારે પ્રોબ્લેમ કરી રહ્યા છે ફોર સર્ટેન એથ્લીટ્સ.
Yeah, we cannot say for sure this is going to happen, but possibly can happen, so we need to be careful. Likewise, I had seen once, I was waiting for my wife, she was running a marathon and I was in support, so I was waiting en route, and there was one girl from Mumbai and she was running like you could see there was knocking, her posture was like this, and she was running marathon, and એવું નતું પહેલી મેરેથોન દોડતા હતા, ઘણી બધી દોડી ગયા અને સારા ટાઈમ સાથે દોડે છે. Then we will not say okay, these are the these are the deviations and we need to correct it, but we need to address on strengthening of the muscles so that it supports the system for a long period of time. Likewise, swimmers say તમે કહો young age માં overload is a problem, and coaches don't understand probably that thing. Overload is a problem in Ahmedabad itself. Average the person is swimming for 4-5 years, so routine में minimum 4 થી 8 किलोमीटर daily swimming करता है, 4 થી 8 किलोमीटर નું swimming. So if you have swam, you would realize what it is, 4 to 8 kilometers. So and it's a repetitive activity, and that is going to cause. અને તમે જો એમનો posture જુઓ, as we said, in a growing age, many of the girls who are very good butterfly, but they don't have very good thoracic posture, they are more like this. So then we don't say she's giving you a medal. નેશનલમાં એના ચાન્સ ટાઈમિંગ સારા હશે, કદાચ મેડલ પાડે છે, પોસ્ચરના પ્રોબ્લેમ છે. So then we don't say that this is a postural problem and correct it. Our focus would be okay, what all factors we can focus on to and she can continue. જેમ કે હું જસપ્રીત બુમરાહ માટે વિચારતો કે જ્યારે નવો આવ્યો ને ત્યારે એમના કોચ બધા જે હતા ને એ લોકો બધા એવું કે we let him continue with his normal style, we did not interfere with his style of bowling. પણ મને એવું લાગે કે ક્યારે કદાચ કોઈ એને એવું કહ્યું હોત ને કે રનઅપમાં ખાલી 2 સ્ટેપ વધારવાના છે, ખાલી 2 સ્ટેપ ઓવર અ પીરિયડ ઓફ ટાઈમ, 1 મહિનો 2 મહિનો ખાલી 2 સ્ટેપ રનઅપ વધારે હોય, પછી 2-3 મહિના પછી બીજા 2 સ્ટેપ વધારે, પછી if that intervention would have been done, I may be wrong, this is my hypothesis, okay, I might be wrong, તો કદાચ એ જ્યારે વર્ષ 2 વર્ષ પછી એનો રનઅપ એટલો લાંબો થઈ ગયો હોત કે એના નેકને ને શોલ્ડરને એટલું એક્ઝર્શન ના પડે જેટલું અત્યારે પડે છે. So this kind of interventions needs to be planned.
So just to add in your
discussion, sir. What we say is usually what I apply in daily clinical practice is don't treat everything you see it as wrong, right? You have to correlate with the sports, you have to correlate with the activity, because you might be saying that Neeraj Chopra is having excessive shoulder and scapular movement, but that excessive scapular and shoulder movement gives him an Olympic medal every time. So yeah, so that's, we need to correlate with the sports, and we need to correlate with the movement, I think.
So can everyone carefully watch his movement, then we'll discuss. So if you see the amount of hyperangulation he is having, now as Samir bhai said, there is a saying in Gujarati, જોયાનું ઝેર. દરેક વસ્તુ જે જોયેલી હોય ખરાબ હોય એને કરેક્ટ કરવાનો ટ્રાય નહીં કરવાનો. This hyperangulation is helping him to achieve the distance and the force. So what everything we discuss is not all size fits all, it is a custom made depending on the expectation of the patient you have to see. Many times we treat javelin throw players who have slack tear, superior lateral and posterior tear. Now, without correcting the biomechanics, if we operate the slap, again when the player returns to play, it will again tear. So nowadays we are not operating the slap tear very aggressively. We are accepting it as a normal phenomenon in overhead athlete. If it is creating too much of issue, then what we do, we leave the slap as it is. We cut the long head of the bicep from the glenoid, and then we attach the biceps at the another point at the humerus. So biceps નું attachment જ glenoid પરથી જતું રહેશે, તો pull જ જતો રહેશે, તો slap જ નહીં થાય. But we cut the biceps and we reattach at another place. We can discuss that at some other point. Now moving, thank you Srinath and Chetan sir. So just before the lunch, we have two more lectures left. One is very common bread and butter topic of everyone, frozen shoulder, and then after that would be the discussing the how to read and the MRI. So I would welcome Dr. Jamin Bhatt. He is the founder of Proactive Physiotherapy. He is very active on Instagram. He has a lot of followers. He is a national and international faculty for many webinars. So he is going to speak today on frozen shoulder.
ગુડ આફ્ટરનૂન ઓલ ઓફ યુ. પહેલી તો વસ્તુ એ જે પાછળનું બધું ડિસ્કશન થયું, હ્યુમન બોડી ઇઝ નોટ a symmetrical, that is perfect. the first thing is human body is not a symmetrical part, and everybody moves in its own direction. At the end of the day, we all have our own movement signature. As sir said about the javelin, we can't change the posture of any athlete. The classical example, the one we have seen right now, the second one, the archery, they have a sway back posture and they come to our clinic and they said that I have a back pain, we can't change that posture. So that is the thing that we must understand. Now come for the frozen shoulder, it's a step to success. These are the differentiation. These all three may develop a frozen shoulder. Okay, the first one is about the dynamic shoulder movement. He may have a rotator cuff injury, he may have a post-traumatic stiffness, he may have any arthritic problem. The second one, post-operative stiffness. The third one, impingement. Impingement can lead to a frozen shoulder in a late stage. It is not about after 2 months the person is developing a frozen shoulder. It may take 6 months or 1 year if patient is not addressing the rehabilitation plan. Now these are the 5 principles that we should understand when we are dealing with the frozen shoulder. The first of all, we need to understand the capsule. As in the initial lecture, sir told about the biomechanics, the superior glenohumeral ligament, middle glenohumeral ligament, and inferior glenohumeral ligament. Inferior glenohumeral ligament has a 2 bands, anterior as well as the posterior. So if we understand the capsule, then it is very easy for us to gauge the full range of motion. If the person has a flexion issue, fine. What could be the reason? He has a dynamic problem in a rotator cuff muscles. That is the first thing. He may have a tightness of a posterior capsule. Okay. So when the person has a limitation of range of motion, આપણે એક ligament affected છે. Okay. If the person has abduction, external rotation, so which are the ligaments? The anterior capsule, as well as superior glenohumeral ligament, as well as anterior glenohumeral ligament will. If you don't get a glenohumeral dissociation, don't start any strengthening exercise. You will developing a strength to the dysfunction. If you know the dysfunction, don't add a strength. And we must understand about the movement behavior. If we know the movement behavior, how the body is moving, how the patient how the patient is doing his routine activity, that needs to be taken care. Let's an example of homemaker. ઉપરથી બધી વસ્તુ લેવાની છે, આખો દિવસ કિચનમાં કામ કરવાનું છે. As the previous lecture, sir told about patient exercise કરવામાં લોચા નથી time મળતો. So we have to mimic the exercise which can go into the functional activity. Patient ને homemaker છે, તો એ આ kitchen સાફ કરવાનું છે. So you can start with the closed chain. You can go for adduction, abduction, flexion, extension, the table stride exercise that you can mimic in the kitchen સાફ કરવાની અંદર તમે કરી શકો. So likewise, you have to mold the exercise in a functional way. The most area affected, rotator interval, subacromial bursa, transverse humeral ligament, and the fourth one is subscapularis recessus. These are the 4. And the first one, the transverse humeral ligament as well as rotator interval. These two are, first of all, it is affected along with the corophumeral ligament. Pain increase, patient ને તમે stretch કરો છો, pain વધતું જાય છે, your increase is the inflammation. Stretch, increase the stiffness, increase the inflammation. So whole આ બધું આખો દિવસ ચાલતું જ રહેશે. So we have to identify patient is pain dominant or stiffness dominant. That is more important. આપણે હિસ્ટ્રીમાં ડાયાબિટીસ પૂછે છે. Why diabetes? Because of if the person has more than 10 years of diabetes, they are more prone of risk factor of frozen shoulder. I'm not going too much detail in pathogenesis, but those who have a diabetes, they have a inflammation in the shoulder joint. According to the literature, patient ને એક રાઈટ સાઈડ ફ્રોઝન શોલ્ડર થયો છે તો બીજી વાર નહીં થાય એની કોઈ ગેરંટી નથી. અને થઈ શકે છે કે બીજી વાર ઓપોઝિટ સાઈડ થશે, that is for sure. So the pattern of frozen shoulder, this is self-limiting disease. Painful shoulder in initial stage. Pain is radiating till elbow joint. Progressive loss of glenohumeral motion. Progressive fibrosis, especially inferior capsule. Near the axillary pouch that we all seen in an MRI, there is a thickening of axillary pouch, inferior capsule. Eventually contraction of a glenohumeral joint capsule within 1 to 9 months. These are the typical pattern. એક મહિનાની અંદર પેશન્ટની રોટેશન કોમ્પોનન્ટ ધીરે 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 અફેક્શનમાં આવતો જાય, then we can or we may give a label, but along with that we need to differentiate another pathology. Don't directly jump into the patient has a restriction of one plane motion like an internal rotation deficit. He can perform external rotation easily. Fine. Don't give a label person has a frozen shoulder. The person may have a full range of motion and range problem. We can't give a label the person is into the initial stage of frozen shoulder until we identify another pathology. The causes of frozen shoulder, the primary idiopathic we don't know. Many of times in the late age, after 45-50 years of age, patient ના મને કશી ખબર નથી, ધીરે ધીરે પેઇન શરૂ થયું, fine, અને ધીરે ધીરે internal rotation restriction. According to the literature and from my clinical experience, what I have find it out, patient એક જ બાજુ મને right side સુવાનું જ ફાવે છે. એક જ બાજુ સુવાના લીધે બીજી વસ્તુ પિલોની હાઈટ, proper spine alignment ના હોય. એટલે શું થશે, શોલ્ડર ઉપર બહુ જ વજન આવશે, કન્ટિન્યુઅસ વજન આવતું રહેશે. AC joint will come into the compression throughout the 4, 5, 6 hours. It's depending on the patient's side. And eventually he developed the AC joint pain. And dhire dhire scapula dyskinesia that we give the label. AC joint works as an axis to move the scapula in upward rotation, downward, posterior tilt, anterior tilt. So when you see the AC joint problem, you must address about the scapular dyskinesia. The secondary problem, the systemic, extrinsic factor and intrinsic factor. But in most of the cases, we first of all during the examination we find it out the patient has a diabetes. Okay, he has a shoulder problem. If patient comes to our clinic with the first consultation, in our prescription, frozen shoulder. Don't do like this. First, assess the movement, assess the proper movement as well as end-field. After that, you should give the label. Rotator cuff pathology. Those who have a full thickness rotator cuff tear, patient fails to do shoulder abduction and flexion without touching the patient. Don't think that the person may have a or person has a frozen shoulder. The person has a partial thickness tear, they may develop a frozen shoulder in a late stage if they are not using the shoulder in a proper way because due to the fear factor. So આ બધી જ વસ્તુ ધ્યાનમાં રાખવાની. Now screening of shoulder for a specific frozen shoulder. The first of all, pain location. The coracohumeral ligament is the first ligament that affect in a frozen shoulder. So when the person has a coracoid process tenderness, along with the humeral course, humeral head, plus rotation restriction છે, abduction કરતી વખતે internal rotation થાય છે, that is the classical sign the person has a frozen shoulder. Okay, પછી અહીંયાના બધા મસલ્સ પણ વિચારવાના આપણે. એવું નહીં કે ત્યાં છે, અહીંયા કયા મસલ્સ આવે? Which one? Coracoid process?
Subscapularis.
અરે બોલો, ભૂખ લાગે છે હવે તો. નથી બોલાતું. It's a short head of biceps along with the coracobrachialis. The type of movement pattern, internal rotation, palpation and functional restriction. The frozen shoulder is also depending on the age factor also. The functional restriction, internal rotation, combing of hair, આ બધું જ પહેલા આપણે બધા ડિસ્કસ કરી લીધું. The overview, but આ બધી જ વસ્તુમાં how to improve the range of motion that I will tell you. So you can go for the surface marking and find it. This is the coracoid process, clavicle, and this is the acromion. So I would insist whenever you are doing the shoulder examination, do the surface marking. That will help you which structures પેશન્ટ ક્યાં તમારો હાથ મૂકે છે, એન્ડ એસી જોઈન્ટ છે, પામ સાઇન છે, એન્ટીરિયર એસ્પેક્ટ પર છે, પોસ્ટીરિયર પર છે. The clinical presentation: anxiety, fear, burning pain, disturbed sleep, distress, life on hold, jerk type of movement. સર ક્યારે આ શોલ્ડર થશે? છેલ્લા 3 મહિનાથી મને ઊંઘ નથી આવતી, મારું કામ અટકી ગયું છે, મારાથી આ વસ્તુ થતી નથી, ઘરમાં કોઈ મને મારી જોડે વાત નથી કરતું, બધા જ મને કે કરે છે કે તમે એક્સરસાઇઝ કરો, દવા લો. આ બધી જ વસ્તુ પેશન્ટના મગજમાં ચાલતી જ હોય, બીકોઝ ઓફ કે નોટ એબલ ટુ પરફોર્મ ધ ફંક્શનલ એક્ટિવિટી. સડન ઓનસેટ યુનિલેટરલ પેન, આ બે વસ્તુ એવરી ડે ઇન્ટર રોટેશન કરતા એક સાઈડ ફ્લેક્શન માં જતી રહે ટ્રંક. ઓકે, એન્ડ ધીસ ઇઝ અબાઉટ કોમ્બિંગ ઓફ હેર. The sudden onset unilateral pain, range of motion restriction, active is equal to passive range of motion, ADL restriction. In frozen shoulder, from your screening part, as in previous lecture, how much time do you have to give an assessment? According to the Vladimir Chanda, he said that if you give a maximum time in your assessment, that will save your time in a treatment. So jetlo time assessment karo, do screening, assessment, treatment, and again do the screening, or you can do the assessment, as Dr. Ronak said. So બધી જ વસ્તુમાં તમે એક પહેલા ગોલ બનાવો, પછી you should start the rehabilitation plan. So these are the two classical functional limitation. Agree? આવે જ હોય છે કે બીજું કોઈ છે? કોઈ anybody has any idea?
જમીનભાઈ, કોમન વસ્તુ કે કાર ચલાવતી વખતે પાછળની સીટ પરથી કે લેવું હોય ને
તો પણ બે
કાર સીટ.
So, so this is the movement adduction, internal rotation from the external rotation. So when there is a rotation issue, person may have a problem, and there are certain pathologies we need to rule out it. When the person has a problem in belt બાંધવામાં problem થતો હોય. See, think from the patient's movement perspective. I always see from the patient functional point of view. કઈ movement કરે છે, શેમાં પેઇન થાય છે. That is your screening part. Don't jump. મોર્નિંગમાં કીધું બધા ટેસ્ટ કરવા જરૂરી નથી. હવે આ બધામાં તમે બાઇસેપ્સ કરો ને ઇમ્પિંચમેન્ટ કરો, રોટેટર કફ કરો. At the end of when you are going for the impingement test, બધા ટેસ્ટ પોઝિટિવ થઈ ગયા હોય. So પેશન્ટની ફંક્શનલ મૂવમેન્ટ કઈ છે એના ઉપરથી ડિસાઈડ કરો કે કયો ટેસ્ટ કરવાની જરૂર છે. For the positive of frozen shoulder, rule out. Slow progression છે, yes. Pain and stiffness develop થાય છે, that is a yes. You can go step by step checklist for your frozen shoulder. Limitation of activity of daily living, yes. But when there is a glenohumeral limited in all cardinal plane, you can give a label frozen shoulder. But if you have only external rotation limitation, other joints are flexion, abduction is normal, you can't give a label the person has a frozen shoulder. That may be another issue. There may be a posterior dislocation. We can't see the x-ray. In frozen shoulder, x-ray requires. But when you have a not improving in the rotational, when you are not improving external rotation, frozen shoulder could be anything. A reduced rotation with abduction, internal rotation, that is the classical. Abduction વખતે external rotation કરી શકતો હોય, that is not a frozen shoulder. Painful abduction, but external rotation is normal. Sir will tell you in detail about the MRI, but this can be arthritis of a shoulder, post-surgical, subacromial bursitis, subdeltoid bursa. This is the posterior dislocation. Posterior dislocation હશે તો એક્ટિવ કરો કે પેસિવ કરો, એક્સટર્નલ રોટેશન ઇમ્પ્રૂવ થશે જ નહીં. ગમે તે કરો તમે, સ્ટ્રેન્થનિંગ કરાવો ગમે તે થશે જ નહીં. So in that scenario, you can go for an X-ray part. When the patient comes to our clinic, most of the time he consulted with many healthcare professionals. It can be MD, it can be any doctor. If they don't have an X-ray, if we know that the person is not improving external rotation, you can refer to the respective surgeon, or you can ask the patient to go for an X-ray. But before that, we have to very much thorough in our assessment as well as our diagnosis. The red flag is about tumor, fracture, or visceral pathology. The person has fear of movement. Patient fails to do internal rotation કરશું પેઇન થશે, એટલે ઇવેન્ચ્યુઅલી પેશન્ટને રોટેશન રિસ્ટ્રિક્શન આવવાનું શરૂ થઈ જાય. અબડક્શન નથી કરતા. પહેલા અબડક્શન કરી શકતા હતા, પણ આફ્ટર 5 10 days 15 days when the pain વધતું જાય, પેશન્ટ અબડક્શન પણ ધીરે ધીરે ઓછું કરતું જશે. General psychological distress and generalized illness that needs to be taken care. And in this yellow flag, we have to work from the biopsychosocial model. We need to educate the people what treatment you are going to give, as well as what is the effect, and after how many days you will get relief. પહેલા જ પેશન્ટ સારું ક્યારે થશે? છેલ્લા અઠવાડિયા 3 મહિનાથી 2 મહિનાથી પેઇન વધતું જ જાય છે, ઓછું થતું જ નથી. So we need to identify whether the person is doing too much exercise, too much activity, whether he is taking regular medication or not. કોઈ એક જ વસ્તુ પર સ્ટિક નહીં રહેવાનું. Don't marry to the single system. You can use the DASH outcome measure, the SPARDI index DASH, that you can use to give the patients, for the patients, outcomes. પેશન્ટને આપણે ડોક્યુમેન્ટેશન કરીશું તો બતાવવામાં આવશે કે હા પહેલા તમારો સ્કોર આ હતો, અત્યારે આ છે. So it is very easy for us to make them understand, and it is very easy for us to go to the next level of an exercise regime. And SPARDI index is about routine active. આપણે જે ક્વેશ્ચન પૂછે છે એ જ છે, પણ એક જ વસ્તુ છે, આપણે કોઈ ડોક્યુમેન્ટેશન કરતા નથી. આપણે કશું જ નથી હોતું, શું વધ્યું શું નહીં. આજે કીધું હા પેઇન સારું છે, બીજા દિવસે કે ના ફરીથી પાછું એનું એ જ થઈ જાય છે. એટલે આપણે કન્ફ્યુઝન, હવે કરવાનું શું, ગઈકાલ તો સારું કીધું, આજે કેમ આવું થઈ ગયું. So it is all about our problem. આપણે શું પૂછવાનું છે, close ended, open ended questions that we need to ask to the patient. We need to find it out. In single session, if you find the patient is improving very well, next session it is 100% sure patient is improving 20%. If it's not improving 20%, find the cause why patient is not improving. And in between, today you have given the fantastic exercise, tomorrow patient is not coming, the day after tomorrow patient is coming to your, if he says it is very well, बहुत सरस से improvement ઘણું સારું છે, you can ask the patient to come as an alternate day. Okay, so that will give you an idea about how you have to manage all the patients. બધા જ પેશન્ટને 20-25 દિવસ બોલાવવા જરૂર નથી હોતા. કોઈને રોજ રોજ આવું કંટાળો આવે, 5 કિલોમીટર 2 કિલોમીટર even 1 કિલોમીટર હોય ને રોજ રોજ તોય કંટાળો આવે. તો find it out how patient is behaving in your clinic. If you cut it down, short period of time, patient is very happy. But on the other side, patient should be adherence to an exercise program. That is very much important. So now exercise prescription. બધી જ વસ્તુમાં હવે ક્યારે શું કરવું હવે. સરે કીધું કે ભાઈ તમે and go for a maximum time in assessment, treatment, બધી જ વાર્તાઓ બધાને બધી જ ખબર છે, આપણે બધી જ બુકમાં વાંચ્યું છે, પણ કરવાનું શું, કેવી રીતે શરૂ કરવાનું. ઓકે, many of you maybe know. First of all, you should do the plan. કેવી રેન્જ તમારે વધારવી છે, કેટલા મહિનામાં, સોરી કેટલા વીકમાં તમારે, how you have to improve, that you have to decide it. Let's an example, 2 વીકમાં મારે રેન્જ ઓફ મોશન ઇમ્પ્રૂવ કરવી છે. ઓકે, તેના માટે શું કરવાનું આપણે? You have decided કે 3 session per week. This is just an example. 3 session per week, home exercise program, improve the capsule flexibility. Check at 10 days or at 12 days, 15 days, it is up to you. Final check by 3 to 4 weeks. And after that, you have to execute what you have decided. It is all about the goal met, define new goal. If goal do not met, why and what you have prescribed, and then you will get the success. This is all whole story for each and every joint. Not I am talking about only frozen shoulder. Okay, 2 week પછી 3 week પછી નથી ઇમ્પ્રુવમેન્ટ મળતું, don't just wait for same treatment. You will know, understand about your treatment affection within 5 or 7 days. Within 10 days, you will understand how the patient is progressing. If patient is not progressing even a single degree, in session, you are improving the range of motion, but tomorrow the patient comes with the previous range of motion, the same. It is all about our selection of exercise is totally wrong. From the treatment point of view, it is not a one condition. Pain, when there is an inflammation, neovascularity, the sensation, the stiffness, capsular contracture, or a fibrosis. That we need to identify pain dominant or a stiffness dominant. In pain dominant, better to tell patient to get for the NSAIDs. Patient એવું નહીં કહેવાનું કે ના દવાઓ કઈ કામમાં નહીં લાગે. આપણે બહુ સારા equipment છે. We can't change the chemical composition by the physiotherapy treatment. ઘણી બધી આવી છે, લેઝર છે, આ બધી વસ્તુ છે, but certain extent there is some limitation. So જ્યારે પણ NSAID ની જરૂર હોય તો આપવાની જ. The range of motion વધશે નહીં. The treatment based classification, the constant pain, high levels of pain, night pain, high irritability. It is very difficult to treat such kind of patient. Severe pain સાથે આયા હોય. We have applied ISTM, cupping, બધું જ વસ્તુ આપી આપણે 5 દિવસમાં. બહુ જ પેઇન છે. When patient comes into the pain predominant phase, don't give any manual therapy, don't give any resistance training. Let the joint calm down, let the pain subside, wait for an inflammation reduction. Otherwise જેટલું inflammation વધશે એટલું stiffness વધતી જશે. જેટલી stiffness વધશે એટલું 15-20 days પછી સર્જન તો આપણને ઇન્જેક્શન આપીને મોકલી દેશે. પછી જે સ્ટ્રેચિંગ આપવાનું હશે એમાં પેઇન વધતું જશે અને સ્ટીફનેસ વધતી જશે. પેશન્ટની તો ધીરજ જતી રહી હશે. 2 મહિનાથી તો આમ ફરતો હશે. અને પછી એમ કહે કે ભાઈ મારે તો 10 દિવસમાં થઈ જશે. એટલે કેવું છે આપણું મગજ? 10 દિવસમાં થતું હશે? એટલે બહુ ખેંચમતાણી નહીં કરો. A stiffness dominant હશે તેના characteristic intermittent, no pain, no night pain, low irritability. તમે ઘણા લોકો પેશન્ટને જોયું હશે, પેશન્ટને કોઈ જ પેઇન નહીં હોય અને સ્કેપ્યુલા ડિસ્ફંક્શન હશે. Frozen shoulder, second one, post traumatic stiffness, plating કર્યું હશે ને પછી એકદમ abduction કરો કે ફ્લેટ નથી, પેન જ નથી. તો એમાં કરવાનું શું? We have to think from the fundamental point of view. We have to stable the scapula. If scapula is not stable, આપણે સવારથી scapula ચાલે છે. Nowadays, the trend is about the rotator cuff related shoulder pain. We should not forget about the scapula. It's kind of wavy literature. You can find it out on a PubMed, Embase or Cochrane. Now people are more moving into the shoulder pain. You may have a rotator cuff problem. So we have to think both the sides. Both are in a different types, scapula as well as rotator cuff, but we need to balance both the tribes. Pain predominant, education, supervised exercise, medication, or corticosteroid injection. Severe pain, don't touch the patient. TENS, ultrasound, whatever you have given 5-6 days. If we follow the pathology within 7 days, the inflammation is about to subsiding. 7 days, patient has a still pain, don't continue the session, refer to the orthopedic surgeon or respective doctor from where he comes to our clinic. And the stiffness, education, stretching versus hydrodilatation and the surgery. This is the surgical procedure, hydrodilatation. It's about the surgeon is injecting the saline in a glenohumeral joint more than 15 ml because the joint is acquired only 10 to 15 ml. And they just burst the capsule and that will improve the range of motion easily. So the key points of management: differentiate pain versus stiffness. That is more important in a frozen shoulder. Share decision making with patient. Sometimes patient says મને આ એક્સરસાઇઝ કરવાથી બહુ સારું લાગે છે. ઈગો નહીં હર્ટ કરવાનો. ચાલે સારું થાય છે ને patient ને. That is a shared decision making with the patient. મને હું આ કરું છું તો મને બહુ સારું લાગે. જવા તો 2-3 દિવસ તો ખબર પડી જશે કે ના પેશન્ટ ક્યાં સુધી શું કહે, સાચું કહે છે, ખોટું કહે છે. Sometimes we also wonder patient સાચું છે ખોટું છે, રામ જાણે. આપણે આપણી રીતે ના, આપણું ઈગો હર્ટ થઈ ગયા. આપણને શીખવાડવામાં આવે પેશન્ટ. 90% પેશન્ટ આવું જ કહેતા ગૂગલ ડોક્ટર. સર ડાયગ્નોસિસ જ કે છે મને ફ્રોઝન શોલ્ડર છે તો ભાઈ આયા શું કરવા અહીંયા તમે ખબર જ હતી તો ટ્રીટમેન્ટ લઈ લેવી હતી. So that is a shared decision making. I'm not talking about the diagnosis જોડે તમે patient ને convince થાઓ. Pain predominant corticosteroid injection 6 weeks effect. It may last more than 6 weeks. It is not our hand. It is about the body's physiology. Stiffness predominant, mobilization and stretching. If it's failed, surgical intervention. Okay. Now I will go from the high level irritability to the low level irritability of rehabilitation part for the frozen shoulder. High level irritability, they presented with the night pain, resting pain, active range of motion is less as compared to passive range of motion, pain before end range. 24/7 patient ne a pain hoya છે, resting pain, night pain, શું કરવાનું એમાં? What is your opinion? Let me know. What is your opinion? Patient comes with a severe pain. You have given a diagnosis, frozen shoulder. What is the first line of management? Chalo, common it khali. Whatever you are saying, it's absolutely right. Anyone? આજે સિવિયર પેઇન છે, પેશન્ટે દવાઈ લીધી છે, બધું જ કર્યું છે, પેશન્ટે ઇન્જેક્શન લઈને આવ્યું છે, તોય એને પેઇન છે. શું હશે પહેલી જ વસ્તુ? પહેલા 3 દિવસ શું પેશન્ટને આપણે સમજાવીશું, શું કહીશું આપણે? It is all about the education. It's about the prognosis. It will take a minimum of 7 days if the patient has a severe pain, because we can't change the physiology. Okay. The focus on posterior capsule. The posterior capsule, why? Because end range full flexion, it requires the flexibility of posterior capsule as well after 150 degree. If posterior capsule is not adequately stretched, you will not get a full shoulder range of motion, because at the end range the humeral head is also gliding inferiorly to set the socket in the glenoid. Okay, after that we can serve or we can do any overhead activity. So for that, the area where I have do the ischemic pressure, or you can give a gentle, not give a too much pressure. દબાઈને patient બૂમ પાડે એટલે સુધી નહીં કરવાનું. So that is why I told you to do a surface marking that will help you where the exact muscle lies. આપણે બધા કઈ આવે ને એટલે અહીંયા દુખે છે, હા દુખે છે, પ્રેશર જેટલું આપે ને પેશન્ટ ના દુખતો હોય ને તોય દુખે, અને પછી આપણે પાછા બીજા સ્ટ્રેચ કરીએ અને એક્સરસાઇઝ કરીએ, બહુ દુખી ગયો એટલે ડાયથર્મી ચલો, એટલે પ્રેશર માપનું રાખવાનું. ઓકે, so the focus on posterior capsule. You can also go for the standing posterior capsule stretch. But the thing is, many of times you have a diagnosis, posterior capsule tight છે, પણ ક્રોસ આર્મ અડક્શન કરવાનું નથી, સ્ટ્રેચ તો મળતો નથી, તો નહીં હોય કદાચ, ચલો જવા દો, ખોટું હશે. ઓકે, એટલે આપણે મૂકી દઈએ બાજુ પર. This is not the way. When the shoulder is into the elevation position, okay, when you are doing the horizontal adduction, the capsule will not stretch. If you are doing in a standing position, if the scapula is not stabilized, it requires a proper stable base. So when the person is too much pain, you have a not too much pain, the person has a pain and he has a posterior capsule tightness, start exercise in a supine line to give a scapula a stable base. Okay. Along with that, I will tell you the fault which we are usually performing in our clinical practice, but sometimes we know, sometimes we don't know, and we will not get the proper results. બધું જ કર્યું છે સર, મેં પોસ્ટરી કેપ્સ્યુલ આપ્યું, સ્ટ્રેચિંગ કરાવ્યું છે, નીડલ કર્યું, આ કર્યું, પણ ટ્રીટમેન્ટ નથી મળતી, ઇમ્પ્રુવમેન્ટ નથી મળતું. સેમ વસ્તુ બધા જ સેમ એ જ વસ્તુ કરતા હોય પણ ઇમ્પ્રુવમેન્ટ મળતું નથી. The reason is the way of performing exercise. Somehow we are compensating some another joint, but we miss to diagnose that things. So initially, when you have a less range of motion, you can start with a low grade of shoulder flexion. Okay, you can go for the low grade of shoulder flexion, but the thing is that the scapula should not too much protracted. If the scapula is too much protracted, you will not get the posterior capsule stretching. Tomorrow, if you have a patient, do that. अरे जो patient ने એટલો stretch નહીં મળે. Eventually, you can go for a 90 degree. આ બધી જ એક્ટિવિટીમાં AC joint પર પેઇન આવવું ના જોઈએ. If AC joint પર પેઇન આવે છે તો the humeral head is too much translating superiorly. Even though in a supine you are performing the shoulder flexion, still the problem is the glenohumeral joint is not working separately. That is why after 60 degree or a 50 degree, person has the elevation of shoulder joint and you are doing the posterior capsule stretch, person may have a pinching type of pain at the AC joint. Okay, so આ બધી વસ્તુ ધ્યાનમાં રાખવાની તો ઇમ્પ્રુવમેન્ટ જલ્દી મળી શકે.